intensivist and emergency department. He was a former chairman of the intensive care department, and currently he is the deputy executive director of medical and clinical services at King Faisal Specialist Hospital and Research Center, Jeddah. Um, Dr. Hassan Sharif, Major General. Dr. Hassan Sharif, he is also a consultant intensivist and pulmonologist, chairman of the intensive care department, and medical director at King Fahad Military Hospital, Jeddah. And myself, Fahad Smith, intensivist and pulmonologist, chairman of the intensive care department, King Abdulaziz Medical City, and King Saud bin Abdulaziz University for Health Sciences. Uh, I will leave the floor for Dr. Ismail to introduce the first speaker of our session. Thank you.
Assalamu alaikum. Good morning, everyone, and thank you, Prof. Fahad, and welcome you in the 13th Saudi Critical Care Specialty annual meeting, and welcome back in Jeddah. Bring us again, as Dr. Yasser mentioned, 10 years ago when we started in 2010. So happy to see everybody in Jeddah. We say Jeddah Ghair. Inshallah, you enjoy your stay. If you are from our cities, you enjoy your stay in Jeddah. Our first speaker in this session that talk about it, one team, one goal, and advancement in critical care. It gives me great pleasure and honor to present Dr. Khalid Arabi. Dr. Khalid is a consultant senior from King Faisal Special Hospital, Riyadh. He was a former chairman of Department of Critical Care Medicine and have a lot of work in the foundation development, system organization, and critical care medicine. Dr. Khalid is going to talk about critical care year review. Dr. Khalid, the floor for you. Thank you.
Good morning. Bismillah, alhamdulillah, wassalatu wassalamu ala rasulillah. I would like to thank the organizing committee for asking me to talk to you today about critical care year review. When I was thinking about how to do this talk, I want to link this to be interesting for everybody, and I was searching in the literature over the last year, and I would like to link what I'm going to present to some clinical questions that we may face daily, so we share some interest and some knowledge. As the evidence are evolving and changing, and we have to be really updated and we see what changes. So I went through a few things in the literature and talked to about most of them. And one common question that if you have a patient who's hypertensive, they will ask you what you should do, please give fluid. But next question, what type of fluid? And then the next question, how much you should give this patient? So it's a very common question. And previously we know that there are some evidence that probably saline with balanced steroid and normal saline in adult patients. So this is a stronger evidence, and they've included the study that I mentioned earlier, and they look at overall mortality, and we notice here the overall mortality, the whole analysis for the overall mortality favoring the balanced crystalloid. That's something we have to keep in mind. We look at acute kidney injury development, and also there is a reduction in the development of acute kidney injury favoring the balanced crystalloid utilization. And they looked at the need for renal replacement, and there was no difference between the two groups. So still, the evidence, which if we consider systematic review, is a stronger evidence compared to a single randomized control study, the evidence supporting using balanced crystalloid in critically ill patients. This is something positive, but all the time you have to ask, is it the final answer? Probably no signal. Probably is not, so we would like to look for other patient population may benefit more from that. And I had the patient in the emergency department, in the crowded emergency department with severe ketoacidosis, and I have no bed in ICU. So trying to see how we can shorten the stay of these patients. So this is a study looking at the use of balanced crystalloid in patients with diabetic ketoacidosis. They included a small number of patients, 90 patients. They compared both of them, and they looked at the recovery of ketoacidosis. So if you know, if you treat a ketoacidotic patient, when you finish from the ketoacidosis, you will finish with a normal anion acidosis related to the chloride solution that we give during resuscitation. It's from their control, and they have to show that. Can you put the slide presentation as a presentation, please? Unfortunately, I could not control it. So they look at this small group of patients, and they basically measuring the base X's, and they went into different analyses to see the recovery of the base X's with medication for acidosis. But I would like you to take a look at systematic review that includes this study in addition to other 7 studies looking at ketoacidosis and using of balanced crystalloid. And the same thing, they looked at the effect of on-time decay resolution. So I think for me, time is very important for diabetic ketoacidosis. You blood is beating, you send them to the floor, you don't bring them to ICU. I think time is very important, so this is significant, and there is a significant difference, and favoring the use of balanced crystalloid. And the other thing that reduced the length of stay, maybe in the emergency department, and the length of stay in ICU and then the hospital. So I think this group of patients probably will be more liberal using balanced crystalloid in this patient, but same thing, reflection that your sodium bicarbonate is increasing more in the patient using balanced crystalloid. So the certainty of this evidence is low to moderate certainty, and I think if you look at the very high certainty evidence in the literature, there are few evidence. So this is, I think, enough based on what we see in response to chloride solution. And then how much, and this question, I had a patient with ECMO, and BB and she was hypertensive, so my colleague said, we'll give fluids for the first few days, and then we have to slow down in the fluid. Definitely, I will not give more fluid after 3 days. The next day I was on call, and the patient was hypertensive. And it clicked in my mind, should I give fluid or just go to the conservative way? So this study is an over-randomized, open-label study. They look at restricted fluid utilization in patients with septic shock compared to the standard way. They included good number in the final analysis for more than 700 patients in each group. And of course, would you like to do something, you will ask, what about side effects? What about the outcome of this patient? And this is a good study to go through. And if you look at the two groups, they look at IV fluid, accumulated fluid, including IV fluid and non-IV fluids, and accumulated fluid balance. There is a difference between the restricted group and the standard group. And as we know nowadays, we go for resuscitation, stabilization, deresuscitation, so the amount of fluid is very important. So there is a clear difference. But they found there is no real big change in survival rate during 90 days. And again, some analysis we like to do. So about the patient has odds ratio for mortality in somebody has high extravascular lung water. If you have the ability to measure it, so those patients who have extravascular lung water, they have higher mortality. So this is the good analysis for the risk ratio, and it is 1.69. So there is 1.5 or more time of mortality increase if you have a patient with. So if I have the ability to measure the extravascular lung water, I have to reduce it. This is going to increase mortality, and it is clearly shown in this analysis that the main difference in the extravascular lung water is different from survival and non-survival. So implication clinically, you can use restrictive fluid therapy or standard way, but if the patient has extravascular water, pulmonary edema, they have high mortality, probably you have to go to restrictive fluid therapy, and maybe in the future we have more information about this. Sedation is very important, and every time we have to pay a patient, then what type of sedation we try to use. We love dexmedetomidine. Some people, they oppose what we loving, and they say no, yes, cost, delirium, all these things. So this systematic review of 77 randomized controlled studies, including 11,000 patients, comparing dexmedetomidine with different sedations. So there are studies looking at Brisidex with propofol, midazolam, different things, including usual care, which is not differentiated, what is the sedation used. So different sedation. So this is including comparing dexmedetomidine to different sedation, and what they found that definitely for delirium it proved to be effective. And delirium is something really of concern in patients in critical care medicine related to mortality, outcome, ICU stay, different things related to this. So definitely it has the benefit compared to it. So okay, is there any other benefit? Probably lower mechanical ventilation, lower ICU stay, but the fear of Brisidex all the time is the hemodynamic instability, which is show that it was more hypertension, more bradycardia, maybe more arrhythmia compared to the other sedation. But if I compare the hemodynamic and somebody who's hypertensive with propofol, I found difficulty to see which is better. So in here, I think I love to use it, especially it fasten the extubation for this patient. For sedation, we know that ECMO utilization was, shall I give her hypertonic saline or mannitol in this situation? And I found this article. They looking at 51 patients with acute liver failure with brain edema, and they compared 20% mannitol to 3% hypertonic saline. And what they found that they are good, both medications, they are good in terms of reduction of intracranial pressure. But rebound hypertension was this in the hypertonic saline, and probably I do feel comfortable using hypertonic saline compared to mannitol because of this monitoring and community regulation with renal failure. The interesting thing for this patient, it was first time for me to see such patient. She had quadrivaresis which we know her up, and this improved by time, and this is probably related to the edema and effect. And finally, we discharged from the ICU with some neurological deficit. So I think for hypertonic saline in this situation, probably yes. And then many things were talked about vitamin D and its utilization in ICU, going back till we really get rid of how we can use vitamin D. Is it something to consider or not? But I think we have to see what's in the literature. This is a systematic review, a meta-analysis, including 16 randomized controlled trials, including 2,409 patients, and they look at vitamin D administration either enterally or parenterally. And if you look at the studies included, there are some studies that have only one dose of vitamin D, some studies that have multiple doses of vitamin D. And in the analysis, they look at overall mortality, and they separate the two routes of administration, either enterally or parenterally, and they found a difference in mortality if it is given parenterally. But if it is given enterally, and this is going to be related to the bioavailability of vitamin D upon enteral administration. The other thing, the length of ICU later state, probably it is better. You can see that here the ratio, and it is giving favoring vitamin D if it's given parenterally, mechanical ventilation duration in this group. So is it the end of the chapter for vitamin D? I don't know. Maybe in certain patient population, patients who are not moving, patients who need to get them up from bed, patients on steroids. We have to consider vitamin D. Not all the study looking at the level of vitamin D in these studies, but this is something also can guide us. So by this, I think I'm approaching my time. I conclude this talk, and I hope that I share some useful information reviewing the literature of critical care over the last year. Thank you very much.
Thank you, Dr. Khalid, for this excellent presentation. For the sake of time, we will delay the question and discussion to the end of the session. The second speaker is Professor Jim Vincent. He is a well-known intensivist and leader across the globe. He is professor at the University de Brussels and also Erasmus University. He is well known as the founder and the chairman of the Brussels Intensive Care and Emergency Conference for almost more than 4 decades. I had the pleasure to attend this meeting for almost 18, 20 years in a row because of the significant scientific enrichment of the conference and the magnificent of Brussels city. He has published more than 1,000 in terms of original articles, abstracts, books, and chapters, and he's been involved in many societies and committees. He's going to talk on the future of the critical care globally. Professor Vincent, thank you.
Thank you very, very much indeed. It's a real privilege, honor, to be invited again at this society. It's really great to be are changing so rapidly because of the improvement in technologies. And I'll speak later about artificial intelligence and how it will affect our field. But this morning we will see how the hospital will evolve in the future and how critical care medicine will evolve. But this is already going on, and I see that after me there will be another talk on telemedicine. Telemedicine will really change our world absolutely, completely. And this is just to give one example. And during this talk, I would like to emphasize that these technological developments should not really prevent us from being human with our patients. And patients will still need a good doctor at the bedside. This is, of course, very, very important. Now, we could start with the hospital of the future, just emphasizing that the hospital of the future will no longer be extremely big, as we have seen in the last decades. There are still many very big hospitals in many places in the world. Clearly, shorter hospital stays, less hospital stays, earlier discharge from hospital. We no longer need so many rooms in our hospitals. But the big question for the future is, should we keep small hospitals in the periphery, or will these be just places where patients will pass by and be transferred to bigger hospitals if they need more attention, if they need more sophisticated management? And that's really a very big question, because if with telemedicine we can help our colleagues in smaller institutions to continue to take care of these patients, that may be very good. Patients may be happy to stay close to their home. The family members may be very happy to visit without having to travel large distances. And so it makes sense with telemedicine to keep patients who are in small institutions in these small hospitals. But at the same time, we may argue that it's more valuable to transfer these patients in large university hospitals where they are more used to treating these particular cases. With COVID-19, we had long discussions about the need to have ECMOs everywhere, or transfer patients to big institutions where they use more ECMOs, so that we could actually have a better management of these patients with severe respiratory failure. So we could argue in one way or another, and that's a challenge already for the hospitals of the future. I know you have beautiful hospitals in Saudi Arabia, and I have visited some, but the hospital of the future will be like a five-star hotel, like a hotel like this one. It will be beautiful, because there are some interesting data showing that the outcome is better when the hospital environment is nicer, and when you are in a room with a nice window looking out at the garden, you will actually have less pain, feel more comfortable than if you are in a small room with just a small window and nothing else. So I'm continuing to speak here because we are waiting for the slides. Apparently there is a little problem there. But I can continue for hours if you like. question is, and we wrote a paper, it's also open access. We wrote a paper on this saying, you know, if now we have surgery that can be conducted a few meters away, with the improvements in technology, it could be conducted kilometers away. And so the surgeons could be in Riyadh and operate in Jeddah or the other way around. So we could actually have the procedure done in any institution if we have the right connection. And it's the same for myocardial infarction. Right now, we discuss the rapid transfer of the patient to another institution to have the PTCA performed by experts. But we could have it in smaller institutions if they have the imaging facilities and just the doctor who will introduce the catheter. And then it could be done in the distance. So, as I alluded to, for ECMO, we had this discussion during COVID. If you hear there is one, should we refer to an ECMO center or not? Of course, it was much prior to COVID. Okay? And you can see there is a difference in mortality. Yes! And what is interesting is that when patients were transferred to an ECMO center, sometimes they did not have an ECMO. Because these centers had the expertise to put the patients in prone position, to manage the fluid, to treat infections, etc., etc. So larger university hospitals. The drones, of course, have changed our lives. We can transfer medicines, blood for transfusions. We no longer need to keep the blood everywhere, just in case, if we have these drones that can bring the blood quite quickly to these smaller institutions. What about a defibrillator? This was, the first one was in Delft in the Netherlands, where you could have a drone bringing the defibrillator. You no longer need to have defibrillators everywhere in your environment. The drone will come and bring it to you right away. That makes sense? Yeah, that's actually a good option. Now, we will speak more and more about trajectories of patients. When I was a visiting professor in New Caledonia, further than Australia down there, people had their little booklets with the blood tests, the medications, etc., so that when people don't know much about it, they just give it to the doctor. But of course, in the future, everything will be available, of course, in a computerized form. But when we arrive at the hospital, and I've seen it for the first time in the Samsung hospital in South Korea, where, you know, when you enter there, people have your entire data about the healthcare status. And so we will no longer hear, as I sometimes hear in our emergency department, have you taken some medications? Have you been ill? This will belong to the past. We will have this information immediately available. And of course, all of this will be interconnected. The technology is there. We could identify arrhythmias, of course, through our smartwatch or anything else, or a little piece on the skin. The problem is how we apply it. Aha, the technology is there, but what will we do when there is an arrhythmia? You know, if the patient has some symptoms, we may say come to the hospital, but without this telemedicine system, the patient should come to the hospital if there is a significant malaise. But telemedicine is no longer only for Algeria, Gabon, it will be for everywhere. So the hospital of tomorrow will have quite loose borders. Right now, when we have a friend in the hospital, we say, how is he? How is she doing? Oh, he was discharged from hospital. Oh, that's good. But in the future, it will no longer mean very much, because the limits between the hospital and the outside world will be some kind of blurred. The patient may go to another institution, the patient may go home, and yet the patient may still require some attention. I was at the University of South Florida just before COVID, and I was surprised when they told me some patients leave the ICU to go home right away. Leave the ICU to go home? In Brussels, we could not conceive that. But you know, immediately thereafter came out these studies showing that the outcome is not bad when you have the system, when you have people who can go home and watch the patient, when you have the telemedicine that allows the interaction between the healthcare providers and the patient. Yes, indeed. And it's in Florida, they had these nurses going with a pharmacist to the patients' homes every day, and with a pharmacist to make sure that the medications are well taken. And indeed, with the COVID-19, we learned a little bit. We could have done better, but we learned a little. That's not my talk. We learned a little bit about how to better monitor patients at home. Aha, very important. With my good friends Art Slutsky and Luciano Gattinoni, we were invited to write this piece, Intensive Care Medicine in 2050. And we said, you know, in 2050, my friends, we will not be there to know exactly what happens in the ICU. But we may have a child in the ICU. And the child could tell us his or her story. And as I indicated, the hospitals will be nicer than today. I took one example that I know well from Lisbon. This is a private hospital in Lisbon, the Champalimaud Foundation. Look at how nice it is. And there is an internal garden. And I'm showing this because this is the ICU room. When you are in the ICU, you can look at the garden outside. And as it is, it has a futuristic view. You already see the big screen in the room. That will be the big feature of hospital rooms in the future. And of course, the coach for the families. And that's exactly what our child would say. You know, the hospital looks so nice here. It's beautiful. Beautiful rooms and very comfortable. And I can even bring books or even little toys that I like. I feel really at home in this hospital. Now, technological advances will make that when someone enters the room, someone enters and has to wash his or her hands. Otherwise, beep, 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 it will be automatically recognized. Now, it's more than just taking some water on the hands. People will have to wash their hands completely. Otherwise, the alarm system will ring. Exactly as we have now, when you brush your teeth, you can have such programs, and if you do not brush your teeth well enough, there will be also a signal. As I have said for many years, hospitals will be smaller, but ICUs will be bigger, so that the hospital of the future will be a large ICU with a few beds around it. And in this article that I was referring to, we even raised the question, are we sure that all critically ill patients will go to the ICU? Maybe we will find a way to keep some patients in the hospital rooms with the organ support being adapted so that we could use it. We open the closet and we find a respirator that could be used in the regular room. We will have defibrillators, which are just worn by the patient. And if there is ventricular fibrillation, boom, it will be done without any human intervention. There will be better collaboration between emergency medicine and intensive care, as we have in our institution with what we call the shock lab. Some of you have visited us and have seen that. It's a 4-bed area, and patients can come either from the emergency room or from the floor and be admitted there, and the staff will come from the emergency department and from the ICU. So we really work together there. This is a case of cardiac arrest coming in, and we put the ECMO in, the VA ECMO right away. As I said, the departments will be multidisciplinary. In many places, they still have the surgical ICU and the medical ICU, and this does not make any sense. A surgical patient is a medical patient with a scar. That's all. Because the complications are the same. We just heard about it. We speak about sepsis, the type of fluids, nutrition, vitamin D. Whether it's a medical patient or a surgical patient does not make any difference. So neuro ICU, the same thing. In the US, they say, oh, I work in a neuro ICU. But in the neuro ICU, it's the same problems. You have patients who need attention for, again, sepsis, analgesia, renal failure, etc. So let's move on. In our department, we have just units 1, 2, 3, 4, 5. I like this American distinction between intensive care unit and critical care medicine, which is much broader. And actually, I will keep some for my next talk on artificial intelligence. But the point is that we will have to leave the ICU to help patients on the regular floor. And I heard that some of you have an interest in rapid response systems, as I do. We need to bring patients sometimes earlier in the ICU than what is done today. Again, it's a question of patient's trajectory. We want to prevent the catastrophe. And we had a roundtable conference on renal rapid response systems, RRS. Some people like to call them RRT, rapid response teams. But RRT, to me, that's renal replacement therapy. So, no, I mean, we need to find an abbreviation that will be understood. We need communication. And we will also improve that. It's another story, but we will improve the way we characterize our systems and our procedures. And the point is that these teams will act before the catastrophe, before the respiratory arrest, before the cardiac arrest. In the future, all our instruments will be better connected. Right now, we have the cardiac output machine here, we have the ECMO there, we have the renal replacement therapy there, and we have our treatments on another computer. We will hopefully have, finally, better connections. And without wires, without all these wires that are really cumbersome. So even EEG could be obtained without wires. So the future will be without all this necessary connection. We wrote this piece with Dr. Michard recently, saying, you know, of course, our monitoring systems will be much more efficient, but also much smaller than they are now. I was visiting this military hospital in San Antonio, where they develop system that can allow you to identify a very minor blood loss before any hypotension, of course, but before any tachycardia, any particular symptom. And so this is as you know, this reproduces hypovolemia in volunteers. It's a lower body negative pressure, so that blood is attracted towards the lower part of the body. And you can see by plethysmography very, very minor changes in blood volume before anything else appears. And that's the future. Very, very small monitoring systems with a ring or with a bracelet. And that will be very comfortable for the patient. We'll have finger rings bringing a lot of information about this. Did you see that? It just came out 3 months ago. It's beautiful. It's in Nature. It is a very small ultrasound sticker which was developed at MIT. So we could have ultrasound sticker on our skin. The technology is now there to provide us with this type of technology. So let's move on, and let's say that if we still have to insert a needle somewhere, it will be done by a robot, or at least it will be facilitated by this type of monitoring system. Even lab tests will no longer be necessary because we will have this information transcutaneously. And cellular monitoring will be provided. We lost some time here, but I will quickly indicate that organ support will clearly change in the future, as obviously we will try to use less endotracheal intubation, which carry local problems and the risk of nosocomial pulmonary infection, what we call ventilator-associated pneumonia, and we use less and less invasive mechanical ventilation now than we used to in the past. Okay? We agree. Now, we are discussing here the various modes of non-invasive respiratory support, non-invasive ventilation, high-flow oxygen, CPAP systems, etc. But going back to Champalimaud, you can hardly see the respirator in the room. It's small, no longer a big machine. Endotracheal intubation could be provided by a robot, but do we always need it? ECMO, I think, will evolve. It will become smaller, more usable everywhere, and it will allow to provide gas exchange without any tube in the throat. So some time ago it was still a big thing to introduce the ECMO, but I think this is our team smiling. They are used to it. It's no longer a big thing in big institutions like ours. Look at the nurse here smiling. Yeah, I like to take care of a patient with ECMO, but we will use it more and more. No doubt about this. And the ECMO systems will become smaller, more easily used. So we could very well avoid endotracheal intubation, allow a patient like this. I will show her again when I speak about sedation, how to prevent delirium, because that's the best way to prevent delirium, having people reading books when they are mechanically ventilated. But in the future, we will no longer need the tube in the throat. People will read their newspaper or be happy in their bed with a machine helping to maintain gas exchange. I was so pleased to see my friend Alain Combe publishing this very recently from the COVID-19 experience, saying, you know, we have a patient here who was put on ECMO without having any endotracheal intubation. We just put the lines in, and the machine maintained proper gas exchange. Isn't it nice? And so we could combine it in patients with renal failure with renal support. And renal support will be miniaturized. Look at my friend Claudio Ronco. I was with him yesterday in Italy. He is now inserting a renal replacement therapy system in a neonate. You can hardly see the neonate on the image. But we can do it with very small machines. And now we start to look at combined respiratory and renal support. And we could go on and add now the removal of mediators, even bacteria, removal of toxins. We can support the liver with artificial liver systems. So now we are reaching the multimodal extracorporeal support with possibly a pump to support the heart. And that's what we called ECOS, extracorporeal organ support. We wrote it with Dr. Ranieri and Dr. Brody. That's the future. So, yeah, extracorporeal organ support will be a possibility in the future. You know what this is? It's called a stethoscope. Will you still use it in the future? What for? No, it's nice. Oh, in the past, it was used, but now we just put it around our necks, right? And that's our symbol, because we are healthcare practitioners. But we look at x-rays, we look at echo. Don't speak about the murmur in the heart. I will do an echo right away and tell you how the cardiac valves do function. So, what is the indication? Yeah, to make sure that a tube is in the right place, on the tracheal tube, gastric tube, and to identify a cause of acute respiratory distress. Okay, but otherwise, no, leave it. And even for echo, now we can have these very small machines transmitting images, and we could transmit images from the US to Munich, and vice versa. Again, distance is no longer an issue. And we'll have other monitoring systems. Imaging will be obtained at the bedside, CT scan in the ICU, MRIs even in the ICU. So there will be an evolving role of the specialist, but I will leave it because I realize that our time now is pressing. I will actually go to my conclusion. We'll need less physiotherapists because there will be robots to help patients to move, and we will need less nurses as well. You know, in the past, nurses were giving cigarettes to the patients so that they can feel more comfortable in the hospital. But finally, shall we still need doctors? Good question. Certainly less than in the past, but we still need rounds at the bedside. We still need discussions at the bedside. And I'm concerned about the fact that there is a risk with these technologies, that people make rounds just facing their computers, facing the screens, and forgetting a little bit about the patient who is in the room. These are good friends of mine. I don't want to criticize them. These are excellent centers. They work very well. But in Europe, we like to be at the bedside together and to be able to look at the patient. And finally, the patient experience will be recorded. We'll speak about pain later. We'll speak about comfort. people will fill in forms exactly as for restaurants or hotels. This is in French, but we understand that this is the Michelin list of hospitals with 1 star, 2 stars, 3 stars. And in the US, whenever there is a death, whenever there is a complaint, there is a big structure moving on to discuss it. So there are some hurdles, risks of hacking, but I think we can be very optimistic. I never think of the future, it comes soon enough. Albert Einstein. We can be optimistic, the future is bright. New technologies will contribute to a better care. There is no substitute for humane care factors, and the patient must remain at the center of our preoccupations. It's very exciting. We are living very exciting times, but we will still need people. And perhaps these people will have more time to talk to the patient, to talk to the families, if indeed some procedures can be done more automatically or simply be avoided. Thank you very much.
Thank you, Dr. Vincent, for this comprehensive and interested talk going through the short trip to the future of the critical care medicine. Thank you very much. Without further delay, we'll proceed to the next presentation, and it's going to be about telecritical care experience in Saudi Arabia. Our presenter is Professor Zuhair Al-Asiri. He's a professor and consultant critical care and emergency medicine at King Saud University and Medical City. He's the leader of Adult ICU at MOH, Ministry of Health, and director and the founder of Tele ICU at MOH. Dr. Zuhair.
السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم كل خير. Thank you, Mr. Chairman, for your nice introduction, and I would like to thank the scientific committee for inviting me to talk about our Saudi experience in telecritical care. And I would like to thank Ministry of Health, King Saud University, Darul Uloom University as well, for supporting our innovations in telecritical care. So we move the slide. Great. So the objective of the presentations are the following. What is the new terminology of the tele-ICU? What is the need? Some stories that I want to share with you as well. And what are the outcome and the KPIs that we are looking at when we are talking about telecritical care in Saudi Arabia? What are the models that we decided to go with when we start and establishing the telecritical care in the Kingdom of Saudi Arabia, Ministry of Health? What are the requirements? And some recommendations from our experience the last year. So what is the new terminology that we decide to go? We decide not to go with a tele-ICU anymore. We call it now TCC, and that goes parallel with the recommendations from the Society of Critical Care Medicine that been published and the website. So, and the beauty of having TCC instead of the tele-ICU is basically that could include adult ICU, pediatric ICU, and NICU as well. To start with, let me share with you this nice story. There was a patient with myasthenia gravis in one of the peripheral hospital, which is almost 2 hours flight distance from the peripheral hospital to the tertiary care center. She's known to have myasthenia gravis, and she was admitted to the ICU with acute respiratory failure and worsening myasthenia gravis. So the request was put in the system, and they called 1937, which is the ICU on call 24 hours, and Ministry of Health to cover all the areas. So keep this case in mind, and I'll come back to the presentation later on. We know there is a huge gap between the demand in critical care and the supply. And when we talk about the demand and supply, it's not the hospital, it's not the beds, it's not the equipment. The demand in the HR in critical care medicine in Saudi Arabia and worldwide as well. So the story started almost in 2017 and 18 when we decided to go with the telecritical care to cover the peripheral hospital in Saudi Arabia and to have a better outcome. That what the hope initially, and we decided that we have to provide critical care services to the patient and to the area. So we visited, more than 5 or 6 countries. They are, so advanced in doing telemedicine a long time ago. And we decided to start the service in Saudi Arabia. Now, our theme to start with is basically to access the high quality of critical care medicine for every single patient in the kingdom, especially those under the umbrella of Ministry of Health. That's the main aim. Now, to do this and to know that we have impact about the establishment of the services, we have to have some value-based measure that you should measure to know if you are doing a good job or no. So one of the value-based measure that we decide to go with is basically, عوض ليش يضحك? You are smiling. You are smiling. So the KPI that we decide to go is basically the following. We want to lower the SMR, which is the standardized mortality ratio in Ministry of Health hospitals. And we decide to go with SMR, not with all mortality rate, because we know there is a mix of cases in ICUs. And resources, admission criteria, and ICU stay, because we learned from the COVID-19 that we have major issues in utilization of the bed in ICU. We want to decrease the readmission to the ICU because we know that readmission to the ICU mean high mortality rate by definitions. And we want to decrease the intubation rate. And as well, we want to adhere to the NESM bundles that, a project that started a few years ago with the leadership of Prof. Yassin Arabi, hoping to see the publication soon about it. So we put bundles of NESM as well, one of the criteria. Now, having said that, the first thing that we did, and the first people that we learned from in Saudi Arabia of tele-ICU is Dr. Sulaiman Al-Habib Hospital with the leadership of Awad Al-Umari. That where they started the real tele-ICU, and we learned a lot. We had challenges to start with, but we take their experience in our mind when we start establishing Ministry of Health tele-ICU. We know for a fact the early involvement of intensivists in the care of your patient in the ICU make a difference in the outcome. If the ICU consultant came late, it's already late. It's like the emergency department, the golden hours. There is almost always golden hours in the emergency department and in the ICU as well. So we know for a fact that our early involvement in care of patients make a difference. Not only the intensivist, the multidisciplinary team as well. So we put this in mind when we start our tele-ICU, and this has been shown in the literatures as well. In the meantime, we know that the beds are very, very expensive, the ICU bed, and highly needed. So we decided to what one of our criteria and KPI is to look at the utilization of the resources as a KPI of our tele-ICU. We want to make sure that there is good utilizations of the tele-critical care beds in Ministry of Health. So we put the admission and discharge criteria. There is no single patient get admitted to the ICU without having this checklist being signed by the admitting the MRP or ICU consultant. And we make it a mandate for all the TCC consultant to have this registered every single day. They look at their KPI for all their patients. So in case, for any reason, the patient get admitted overnight from different specialties to the ICU in the open ICU system, we come in the morning and maybe we discharge this patient from the unit if the patient does not meet the inclusion criteria for admission in the ICU. Now, we want to be effective. So what are the effective, how we can make very effective program or services. Khan articles very clearly mentioned there are three major elements of very effective services: excellent leadership, and that leadership including leadership of the telecritical care and our bosses as well, the Ministry of Health, including the minister, the vice ministers, and deputy ministers as well. And we want to have very good people in deciding about clinical decisions, because you see patients remotely, and you have to take very good decisions, and you have to be very precautious before you take any, because one case might communicate the whole services. And we want to have people that are very good in conflict resolutions, because there is almost always the perceptions of our presence in the peripheral ICU could be not very well perceived by some of the HR people in the ICU, because that could be a threat for their presence in the ICU. So we put this in mind when we face any challenges with our colleague in the peripheral hospital. But again, it's a friendship relation between us and the tertiary care in the virtual hospital and our community hospital. We learned a lot from them as well. They get benefit from us being supervising their work. One of the main pillars that we put in the telecritical care, number one, is surge. We should be able to manage our surge capacity in case that we need it. We learned from the corona that surge capacity is one of the maybe weaknesses that we learned, and we have to close the gap in our preparedness for pandemic disasters in the futures. And we want to be not only effective, we want to be efficient in the same time, and that may be met very well with admission and discharge criteria. And we want to have scale up in case we want to increase the services outside the ICU. We want to have a research from the surface, KPI as well, and early patient involvement and patient family involvement as well in the care. And we have a lot of stories where we decide for DNR, goal of care, and stop transfer when we talk to the patient family through the telecritical care medicine. Safety is number one. That should be met with all the domains of the pillars of the TCC. Now we find job for some of the retired people as well, nurses, physicians. They don't want to do bedside round anymore. TCC is the way that you could still practice your knowledge and implement your knowledge for bedside care as well. Now, we cannot start any service, as you know, in the kingdom or anywhere else without having very good governance of the work. So we decided to have the governance that could cover all the medical legal aspect, and that being created by formulating a national committee chaired by expert person, where they put Saudi guidelines for telehealth in the kingdom, and we basically participated when it comes to the emergency and to telecritical care services. That there should be clear accountability and responsibility from both ends, from the command center and the virtual hospital, and from the bedside physicians in the remote area. There is always variations, and that we put this in mind when we do rounds. People do things differently in the peripheral, so we have to put this in mind and people come from different background, different countries, serving our patients in the peripheral. So we put this in mind when we start the telecritical care medicine in Saudi Arabia. Credentialing and privileging, major issues. You should not start your tele-ICU without having the medical director in a certain hospital agreed and thumbprinted, your presence as responsible for the plan for your patient in the ICU. So credentialing and privileging should be signed by the medical director in the assigned hospital as this time. Maybe we might change this in the future. Before we start, we have 3 checklists for us in the command center and Ministry of Health, and for the bedside or the peripheral hospital as well. This is the hierarchy. Tele-critical care or tele-ICU has three models. The continuous one, which is basically 24 hours, and thanks to God that we have, alhamdulillah, now more than 200 million budget to start our continuous tele-ICU covering 150 beds, stage 1, and stage 2 will go to 300 beds. Now, but currently, what we are doing now is basically the consultation model, where the consultant start around at 8, stay in the command center till 4 p.m. to take care of the patient and their plan, and then hand over the cases to 1937, the ICU on call in 1937. The responsive tele-ICU is not in our mandate, but it has been done, especially with King Faisal Specialist Hospital, where they cover some area of the kingdom through the responsive type of tele-critical care. Before we start, we visited the hospitals, and we taught them how to use the machine, how to start the calls, and what is the flow of the patient's care from the beginning till we have the plan at the end of the round for every single patient. By this, we have very good, surge, response, where we can see a lot of patients remotely, and even if the bedside physician are not intensivists, still we could provide excellent care through the services. The case study here done by the GE showed very well, before we start, how much millions that we could save by starting the services, and that's a real fact. And we are planning to publish an article about the cost effective of the tele-ICU in the 20 hospitals that we are covering now. Every single day, the consultant, while they are seeing their patient and observing, the implementation of their plan with the multidisciplinary team, there is always continuous, parallel supervision of the KPI in all the 20 hospitals that we are covering in TCC. Our case, the Martina Gravis, the bedside consultant, the command center consultant at TCC, decide not to transfer the patient, keep the patient over there, and provide the patient with the IVIG. And at the same time, after 5 or 6 days, patient responded very well to the treatment, get extubated and sent home without need to transfer and without the hassles of the cost and the cost and the traumatic, consequences of transferring patient from area to area and from city to city. Maybe our next stakeholders is maybe we get to have more agreement and with the Saudi Council for health specialty, how we can get residents and maybe students involved in tele-critical care services in Ministry of Health, and maybe we have to learn from others as well in the kingdom if they have an experience with involving of residency program and doing so. We could have, for example, resident to come and round in our tele-critical care with the ICU consultant, because the ICU consultant is there almost for 8 hours. So resident would benefit from being there, and they could start the round with the supervision of the consultant. So I think it's an area where we could, improve the skills of our residents in doing telehealth medicine. And accreditations, which hospital and which centers can do tele-critical care is not yet exist in the kingdom, but I think that's one of the things that should be done through the governance bodies. Not every single hospital will start their tele-ICU without have a specific accreditations process to start with. So that my experience in Saudi Arabia, it was amazing, and we have very good outcome, and maybe there is people who start before us, like Dr. Awad Al-Umari and his crews in Dr. Salman Al Habib Hospital, but we learn from others, and we have benchmark locally and internationally. I think our presence in those 20 hospitals made huge difference. We decrease mortality, we decrease readmission, we decrease self-extubations, and we decrease rate of reintubation in those areas. And just wait for the publications about it. Thank you very much for your listening.
Thank you. Thank you, Prof. Asiri, and very exciting, and looking forward to see the works that done published, and I'm sure that will have the great impact on our patient care in Saudi Arabia. Not taking more time, it gives me a great pleasure. I think the next session will be virtually. It gives me great pleasure to introduce Prof. John Laffey. He's a professor of medicine, anesthesia and critical care medicine at School of Medicine, National University of Ireland, consultant intensivist anesthesia at Galway University Hospital. He is also a chair of Ireland Critical Care Trial Group and a chair of Biology Transformation section in European Intensive Care Society. His basic work and research focus on the ARDS and sepsis, and also regenerative medicine for critically ill patients. Dr. Professor Levy going to talk about negative trials in critical care. Are we asking the wrong questions? Professor Levy, the floor for you. Communication, people in communication.
Good morning, everyone.
Dr. John, you are live
Should I
now.
start?
Yes,
You can
please.
start. Yes, yes.
Floor
are
for
live
you.
Now you can start. Yes, go ahead. Dr. John, you can start your presentation. You are live. You can start talking and present your presentation. Thank you very much.
Professor John, can you hear us? Hello?
Good morning, everybody. My name is John Laffey. I'm from the University of Galway in Ireland, and I'm delighted to be talking to you this morning at the Saudi Critical Care Society annual conference. I'll be talking this morning on negative trials in critical care and whether we're asking the wrong question. I do not have any conflicts of interest in relation to this talk. However, as somebody who does clinical trials, I'm very invested in trying to understand why we've had low success rates in trials to date. I don't need to tell this audience the difficulties we've had in terms of negative trials in critical care. This is a large-scale analysis of over 159 randomized trials showing that just 4 for ARDS showing benefit. That is to say, prone positioning, muscle relaxation, conservative fluid management, and lower tidal volume. Not one of these is a trial of a drug to reverse or treat the underlying pathology. And when we look across critical care, and this is an older analysis, suggesting that across the entire spectrum of critical care, that only 14% of trials were positive. This is from over 10 years ago. And in the intervening period, several of these that were originally deemed positive, like protein C, steroids, intramucosal pH, have since been shown to be either ineffective or of uncertain effectiveness. So it does seem that more like 95% of large-scale trials in critical care, whether they be for ARDS or sepsis or other areas, are negative. Now, negative trials are not always a problem. They may remove a harmful therapy from clinical use. They may show non-inferiority of 2 treatments and so allow you to use one versus the other. They may show us a treatment that is similarly effective at lower cost or similarly effective with lower toxicity. However, there are problems with the large numbers of negative trials we have in critical care. We can't really build our future with negative trials. We need positive studies to advance our field. It's not that useful for us to know 100 potential therapies that don't work in critical care. What we need are treatments that work for our critically ill patients. Another significant problem with the negative trials is that we may consign a potentially good therapy to the graveyard by prematurely declaring it to be ineffective. And we have examples of this historically, such as high-frequency oscillation for children, which was initially shown to be possibly harmful, but subsequent trials showed that it was effective and it is now part of the standard of care for severe respiratory distress syndrome. So we may have well-designed trials with good methodology, but we're getting something wrong in our approach. I want to talk a little bit now about a paper that I was privileged to co-author with my colleague, then colleague, the late Professor Brian Kavanagh. And what we looked at was the likelihood that what is happening with negative trials is happening by chance. So if you look at the likelihood at the start of a trial where we have equipoise, we're saying there's a 50-50 chance that the hypothesis is correct or not correct. However, if we do 20 trials in a row and we look at the probability of all of those being negative, that's a probability of less than 1 in a million. So it really is not at all likely that these consecutive negative trials are happening by chance. There is something that we're doing that is fundamentally flawed in our approach. We looked at the Bayesian methodology to try to answer the question of, if we have 20 negative trials in a row, what is the likelihood that the 21st trial would be positive and show and prove its hypothesis? And we could do this by looking at the prior probability of success and the posterior probability. And when we do this using Bayesian mathematics, we see that the likelihood of the next trial being positive is 0.05 or 1 in 20. So although the odds should be 50-50 or 1:1 for our next large-scale trials, the large number of negative trials we've had mean that the likely odds ratio is now about 20-1, which is at the level of a false positive. So I would put it to you in the audience that if you were willing to bet €500 that the next large-scale critical care trial will be positive, I would be happy to match that bet. So I would say it's time for us to change our approach to clinical trials in critical care if we want to move on from the current situation. And I think we have a lot to learn from the COVID experience. We have found multiple treatments for COVID-induced ARDS and also discarded treatments that were unsuccessful. And how did that happen? Well, I think there are a number of reasons. COVID ARDS is easy to recognize. It has a diagnostic test. It has well understood timelines. We know that it generally happens 7 to 10 days after you become positive with COVID. It has a significant and increasingly well understood immunological basis for the condition. It is heterogeneous, but it's less heterogeneous than classic ARDS or the other clinical syndromes we treat in the critically ill. And we've been able to, as a community, to do very big randomized controlled trials using novel platform methodologies. So how do we apply these lessons to other critical illnesses or to classic ARDS, for example? Well, in the next few slides, I wanted to look at some of the possible reasons for therapeutic failures in these trials, and then try to address how we might sort of better design trials going forward. So the first issue is that it is likely that in our large-scale trials of ARDS, which is my exemplar here, or sepsis, includes patients who do not actually have the condition. And we know this from classic studies, such as the study from Thiele et al. Looking at autopsy studies or findings in patients with ARDS, where most patients who had the clinical criteria for ARDS did not have the pathologic hallmark, which is diffuse alveolar damage. We also know that the chest X-ray, which is our gold standard for diagnosing ARDS, is a very poor discriminatory tool. Or more specifically, as doctors, we are quite poor at interpreting the chest X-ray. This is data from the READ study, which was part of the LungSafe set of studies, where a subgroup of investigators were asked to interpret chest X-rays that were classic of ARDS or non-ARDS, either before or after receiving an intervention designed to train them to interpret the chest X-ray. So of the 11 chest X-rays, as you can see in the graph here, you can see that about 6, the average performance was 5 to 7 chest X-rays correct, which is to say no better than chance. Even more concerning, those who had the intervention, which is the training program in black, performed no better than those who did not have the training program. So this suggests the chest X-ray is particularly poor as a tool for diagnosing ARDS, and interventions designed to enhance its reliability are not effective. So I put it to you that it's time to move away from the chest X-ray for ARDS diagnosis. So in terms of addressing this therapeutic failure, we need to make sure that all patients in an ARDS trial really have the condition, that is ARDS. And to do that, we're going to need a revised, better definition of ARDS. A second reason for our therapeutic failure is that even within the true ARDS population, there is substantial heterogeneity. That is to say, there are patients with very different patterns of illness. And we know this at the bedside. We see patients with focal versus diffuse ARDS, for example. And these patients behave differently in terms of their lung compliance, their oxygenation, and likely then will also behave differently in regard to what treatments might work for them. This is a slide from the pioneering work from Caroline Calfee and her colleagues, where she used latent class analysis to identify two subgroups within the ARDS population. That is to say, a hyperinflammatory population, which is about 1/3 of all patients, and a hypoinflammatory population. She subsequently, with her colleagues, went on to show that these groups responded differently to high versus low PEEP and to conservative fluid management, with much of the benefit seen in the hyperinflammatory group of patients, who are those at the highest risk of mortality. This is another approach to identifying subgroups. It's a transcriptomic approach pioneered by the Mars Consortium in Amsterdam. And they identified a reactive versus an uninflamed group of patients with ARDS using cluster analysis of the transcriptome. In subsequent work, they were able to show that a small number of biomarkers, including IL-6, interferon gamma, Ang1, and Pi1, were able to classify these into the inflamed versus unreactive groups. So in regard to dealing with heterogeneity within the true ARDS population, going forward in trials, we need to reduce that heterogeneity by identifying biologically or physiologically homogeneous ARDS subtypes and then focusing on those subtypes in our studies. A third reason for negative trials in critical care is that we frequently enroll non-responders into interventional trials. That is, patients who will not respond to the intervention. And therefore, if they can't respond to the intervention, they can only experience side effects or harm as a result of the intervention. And higher versus lower PEEP is the classic exemplar in this regard. This is the front page of the Alveola trial from the New England Journal of Medicine of higher versus low PEEP done by the ARDS network. And they say very clearly that higher PEEP can improve oxygenation and reduce lung injury, but that it can also cause circulatory depression and lung injury from overdistension. So it's a double-edged sword. It's beneficial potentially, but then also harmful. So in any study with high versus lower PEEP, in the higher PEEP group, you will have patients that are helped by higher PEEP, and you'll have patients that are harmed by higher PEEP. And your outcome then will be some ratio of benefit versus harm in the subgroup that received higher PEEP. So I would put it to you that positive effects in some patients are likely to be cancelled by negative effects in other patients when we do physiologic type trials in all comers with ARDS. So how do we deal with this issue? Well, this is an analysis from Ewan Golliger and colleagues in Toronto, where they looked at the LOVES trial and the EXPRESS trial, two trials of higher versus lower PEEP strategies, and looked at the response to an increase in PEEP. This is the pink line in this graph, and what you see is they looked at the change in oxygenation as determined by the change in the P to F ratio when the PEEP was increased. So if PEEP did not change oxygenation, the mortality rate seen here in the gray arrow was about 40%, or the risk. Now, if the patient had a substantial improvement in oxygenation, seen here as 100 millimeters of mercury of an improvement after the increase in PEEP, they pretty much halved their mortality risk. However, if they had a worsening in oxygenation of a similar level, they had an increase to 60% risk of mortality. So the average effect of PEEP in a study population has no real meaning. It's the effect on the individual patient that matters. This again is the study from Caroline Calfee, where she identified a hyper and a hypo-inflammatory subset within all comers with ARDS. Now, Caroline and her colleagues took the same methodology and applied it to the HARP2 study of simvastatin treatment for patients with ARDS done in Ireland and the United Kingdom. This study showed no benefit in terms of day 28 mortality in the original trial. However, when Dr. Calfee and colleagues looked at the data set, they identified again a hypo and a hyperinflammatory subgroup. When they looked at the hypo-inflammatory subgroup, they saw that mortality was similar in both subgroups, whether they received simvastatin or placebo. So there was no benefit or harm with simvastatin in that group. In the group that was hyperinflamed, as seen here by the darker red line, there was a mortality improvement with simvastatin. So this data is not definitive, it's hypothesis generating, but it does suggest that if we can identify subgroups within the total ARDS population and then target our treatment on that subgroup, we may start to see an effect in that population. So this does suggest that there is hope for precision medicine in patients, provided we can identify ARDS subgroups or subtypes at the bedside. So in terms of addressing this issue, we need to remove non-responders from our clinical trial of interest. So we've got to find a way to identify patients who are more likely to respond to our intervention. And of course, that will depend entirely on what the particular trial intervention is. So we need to find an interim index of response in these patients and then look at that group of patients. So how might that work when you're designing a trial? Well, this is how we currently do most of our trials. We enroll all patients that are eligible to fulfill the Berlin criteria for ARDS. And then we randomize them to receive either the intervention or the standard of care. And then we look at outcome, whether that's day 28 or day 90 mortality in both groups to determine if the hypothesis is proven or not proven. If we were testing a physiologic intervention using a targeted approach, we would take a different approach. So we would look at all patients who have ARDS and screen them for their response to an intermediate test. We would then take the non-responders to that test and not recruit them into the trial. The patients who respond to that test would be randomized to either the intervention or the standard of care. So, and then outcome will be measured in both groups. If we look at higher PEEP, for example, we could look at the P to F response as a test, and then only randomize the patients that have an improvement in P to F ratio. This is also possible with drug treatments. We could identify a biologically relevant subgroup. The group that don't have the profile would not be recruited to the trial, while the group that did would then be randomized to either the intervention or the control standard of care. And this, for example, could be done for steroid therapy, where we might look at those who only have inflammatory ARDS. And if we take this approach, it's possible that we may be able to design smaller trials because we'd have larger effect sizes in the group that were responders. We should have less noise because we've removed patients who can't respond, and less harm because those patients that are likely to have a side effect only rather than a benefit would not be in the study.
1 minute left, doctor.
So in terms of doing the right studies in the critically ill, we need to do studies in the patients that truly have the critical illness of interest, whether that's ARDS or sepsis, and that requires a better definition. And it may be that we need a different definition of ARDS or sepsis for patients that are enrolled into clinical trials compared to what we use daily at the bedside. We need to confine entry to more homogeneous subgroups, whether that's biologically homogeneous or physiologically homogeneous within ARDS. Patients can only respond if the biologic pathway is activated. And if they don't have the pathway, they can only get a side effect from the treatment being tested. But the key challenge, of course, is to identify patient subgroups at or near the bedside in a way that allows you to enroll them into these types of trials. We need to identify surrogate measures that accurately reflect the biological pathway or be a reliable indicator of response to an intervention. So as I say, for PEEP, the P to F ratio response might be such an index, but that would of course have to be proven in a study. So future research needs to focus on enabling this more selective, personalized medicine type approach and allow us to develop the bedside test required to elucidate these surrogate indices of mechanism. Chairs, I'm happy to close and I'd be happy to take any questions. I'm particularly grateful to Professor Almari and Dr. Azam for the kind invitation to speak here today.
Thank you, Dr. Lavi, for this comprehensive presentation addressing very common and interesting questions in the context of clinical trials. Without further delay, we'll proceed to the next speaker. Okay. So our next speaker is a well-known figure nationally and internationally. He is actually currently the chairman of the intensive care department and the medical director of respiratory services and professor at King Saud bin Abdul Aziz University in Riyadh, National Guard. He is the principal investigator and co-investigator for many and several multi-center randomized clinical trials, and he is editor-in-chief for many journals. Dr. Yasin Arabi, please. Thank you.
So thank you very much, and thank you to the organizing and scientific committee for giving me the opportunity to be with you here today. If I can have the slides. I'd like to thank all of you who have participated in clinical research in the last few years. It's been amazing experience and highly productive, and we're looking forward to work with all of you on more research in Saudi Arabia. So if you do a quick PubMed search about critical care research in Saudi Arabia, it really has grown substantially in the last few years. Almost 900 papers related to critical care and Saudi Arabia keywords in 2021. This is really good productivity from our critical care community, but I think this great community is able even to generate more. Along with this, the quality and the impact of the publication has improved tremendously. There are several Saudi critical care projects. Many of you are engaged in some of them or have participated in some of them. I'm going to show you some examples. So also very pleased to have two presentations tomorrow of breaking research, the COVID-prone, led by my colleague, Dr. Walid Hazani, with many centers from Saudi Arabia. And I was privileged to be part of this trial, and also the HELMET trial, which was published 2 weeks ago, both in JAMA, high-impact randomized control trials. So please attend the session tomorrow morning. In the COVID, I think the critical care community responded very nicely, generating many studies. I selected only a few, but there are many, many others that are not on the slide in different aspects of management of critically ill patients with COVID-19. Dr. Zuhair Asiri and I have led the NESAM project. It was a huge project, quality improvement project, started and finished before the COVID-19. And I'll be talking about this tomorrow. It was 42 ICUs across the kingdom to improve the quality of management of mechanically ventilated patients. So a big thanks to the hundreds of people. I'm going to show some slides tomorrow how many people were engaged in this, literally hundreds of people. Some of the work by, from the Saudi Critical Care Trial Group, this was led by Dr. Ayman Kharaba and Dr. Haifa Gathami on the Acinetobacter, really very important topic for our ICUs, showing the prevalence and risk factors and so forth, added a lot to the knowledge about this topic. Randomized controlled trials now becoming more common in Saudi Arabia. This study was led by my colleague, Dr. Mohammed Shahrani, on ketamine, really novel idea on using different alternative approaches to sedating critically ill patients. Many of you have helped in this really different trial, the miracle trial on MERS. And MERS is a disease kind of unique to Saudi Arabia. 85% of cases around the world are from Saudi Arabia. This trial particularly was a challenge simply because the disease was so rare. So it's really hard to do a trial when you don't have cases. So it was a challenge to do a trial over several years to catch these cases that happen sporadically in many hospitals. But this led to a really good outcome showing that interferon beta and lopinavir did actually reduce mortality in patients with MERS-CoV. Along with this, there were, with MERS, again, critical care in Saudi Arabia has produced many articles related to MERS-CoV. Some of them are shown here. Some of these are by several of my colleagues, Bassam Raddadi, Dr. Ismail Qishmaq is here, and along with others. I think the biggest project, at least the one I participated in, is the permissive underfeeding. It's a multi-center study. It was a good experience to build the infrastructure and get things started with Dr. Uthman Sliman, who's here, and several other colleagues. It was a large trial on feeding published in the New England Journal of Medicine, and it's now cited in many, almost all the guidelines on critical care nutrition. And this was followed by the PREVENT trial, another large trial, almost 2,000 patients, of randomizing patients to receive pneumatic compression device versus none, with ultrasounds done twice weekly. So really involved study requires very delicate procedures. This was sponsored by King Abdullah International Medical Research Center, 9 sites in Saudi Arabia, but we were able also to engage sites from Canada, India, and Australia, and led to a really important paper. With the contribution of many of you, we started a research program a few years ago where people have presented their proposals. Some of them are listed here. These proposals have moved along in different paces. So some of them have been completed, some are in different stages. And we would like to keep building on this, and we want the help of others also to be part of the core group of the researchers who provide feedback, help in constructing protocols, guide residents, particularly, which I'm going to talk about in a second. So these are some of the topics that have been discussed extensively. We had multiple research days that where we discussed these protocols at length. Ongoing now, as you know, the Replenish trial. It's 2,500 patient trial of high protein versus moderate amount protein in critically ill patients. We enrolled more than 900 patients so far. And hopefully, we'll be starting the DETECT trial, which will be randomizing patients to biweekly ultrasound versus standard of care to detect DVTs and to see if that reduces mortality. We're also privileged to collaborate with many great networks around the world, the Canadian Critical Care Trial Group, the Australian, New Zealand, and we're pleased to have several of our colleagues here with us. And also recently with the REMAP-CAP, which was mentioned by Prof. John Laffey about the novel designs in research. It's really a novel way of approaching clinical trials. The huge platform trial that includes 52 countries and has led to many positive trials, if you wish, some of them negative. So regarding the management of COVID. So some of them, the IL-6, the hydrocortisone, but many others are coming in the pipeline with this novel design. This design also has brought some of the challenges that relate to the regulatory issues. So we are actually having a lot of discussion with Saudi FDA on how to improve and improve the research process approval. We are conducting this research activity online every month, and we would invite anybody to be also involved in this, where we invite research ideas or protocol to be presented and get feedback from different colleagues. These are some of the lists of the recent ongoing studies and presentation that happened last 2 years in research methodology and resident projects. So in particular, I'm very interested in the research projects for residents, which was started 2 years ago. We have 29 resident projects. Some of them have, in the yellow box, 9 manuscripts have been drafted and some ready for publication. And some of them are actually published, 2 of them. And there are several, 2 of them presented in the American Thoracic Society, and I'm aware of another one will be hopefully presented in the Brussels meeting about no-code status in Saudi Arabia. Very exciting courses to build the capacity in critical care research. The basic clinical research has been conducted now 4 times. The last one was last 2 days. And the basic research coordination course has held twice to increase the number of coordinators across the kingdom in different sites. This is our first course, and this is yesterday. Yesterday courses, really pleased to have great attendance for these 2 courses. Many publications, and this is our annual report that's submitted to the society. So what we are looking forward from all of you is to get more engaged actually in helping mentoring residents and getting engaged in the monthly activity. We want really to incorporate research into critical care training. It is there, but some kind of optional. But it should become mandatory requirements for to produce articles. I think we are moving that direction. We need to also increase the awareness about the ethical guidelines and Saudi regulatory guidelines among the community, so people be aware of how to conduct research in ethical and along the good clinical practice guidelines. And we want to keep up with the educational activities for research. And with this, I would like to thank you.
Thank you, Professor Arabi, for the excellent work and the leadership. As been advised by the organizing committee, and because of the sake of time, we will skip the discussion part. And however, you are all kindly requested to be seated for the opening ceremony. Thank you.
النشيد الوطني. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على خير خلق الله محمد بن عبد الله من أرسل القيم وجعلها من شعب الدين، فصلاة وسلاما عليه وعلى آله الطيبين الطاهرين. سعادة رئيس مجلس إدارة الجمعية السعودية لطب العناية الحرجة الأستاذ الدكتور عوض بن عبد الله العمري،
ينته لنسفعا بالناصية ناصية كاذبة خاطئة فليدع ناديه سندع الزبانية كلا لا تطعه واسجد واقترب.
صدق الله العظيم. لقد كرم الله تعالى الإنسان وعلمه ما لم يعلم، كيف لا وقد تواترت الأجيال في المجالات الطبية تثري وتبرهن وتخطط وتعالج، وأكرمنا الله تعالى بحكومة أولت الإنسان وصحته اهتماماً بالغاً بل وأولوية من أولوياتها، بقيادة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وسمو ولي عهده الأمين الأمير محمد بن سلمان، توجهاً نحو رؤية المملكة 2030. أيها الحفل الكريم، نشاهد سوياً هذا العرض المرئي الذي يشرح إنجازات الجمعية على مدار مسيرتها خلال 13 سنة، يتبعه كلمة سعادة رئيس اللجنة العلمية وسعادة رئيس اللجنة التنظيمية.
يا عاصم، يا عاصم فينك ما ترد علي؟ السبيكر في المطار بيكلموني، فين المواصلات؟ يا عاصم بسرعة لو سمحت، المؤتمر بدأ.
نجلة الله يسعدك، بالله يقول يا عبد الله غبيشي يبطل يعزم ناس للمؤتمر، المؤتمر اليوم لسه قاعد يعزم ناس للأسبوع الجاي، ترى من دفع الجمعية ما حتدفع لهم شيء. خلاص المؤتمر يغلق، قول يا عبد الله يبطل يعزم أحد. شكرا.
متى انتهى على الخير المؤتمر؟ واحد والله استوى خلاص.
يلا هانت الحمد لله، الأمور ماشية كويسة، ورش العمل خلقت الحمد لله.
كيف كان حضور ورش العمل؟
الحمد لله المدربين بس اللي جم.
طب كويس، يعني الأكل كفى؟
كفى وزيادة ما شاء الله، حتى جبنا شوية للمؤتمر.
طيب
يعني إن شاء الله هيكفي الأكل كمان في اليوم.
طيب تمام.
ايوه صحيح، اقول لك دكتور فيصل سلوان دفع غرف المتحدثين.
انا ماني شايفه بس
ترى
ان شاء
المحدثين
الله
ما عندهم
يعني
غرف.
ابو عبد الله موجود يتكفل بالوضع ان شاء الله، ما تخاف.
مين ابو عبد الله؟
يا ابوي ابو رفع عوض العمري رئيس المجلس، لا تفشلنا قدام الرجال.
صحيح صحيح والله ما عليه نسيت، لا ان شاء الله باذن الله في الافتتاح افتكر اسمه.
ايوه تكفى.
هو ليه ما في اضاءة؟
ليه هو المؤتمر بدا؟ فين الاضاءة؟
عاصم يا ابويا فين الاضاءة يا عاصم؟
هو ما في غير عاصم ترى. يا عاصم،
عاصم طبعا احنا ما كنا عارفين ان الميكروفون مفتوح بصراحة، والمفروض انتم ما تسمعوا الجزء هذا، بس حبينا نشارككم شوية من الشباب اللي عملوه لفترة ال6 شهور اللي فاتت والترتيب حق المؤتمر. أشكر الجميع بصراحة الموجودين واللي قاموا على المؤتمر وبقيادة البروف عوض، مجهود جبار جدا. ودكتور وائل يعني رئيس اللجنة التنظيمية مجهود كبير جدا اللي قام عليه عشان يصير المؤتمر بالنجاح هذا، وبفضلكم طبعا الله يديكم العافية، فنشكركم.
أنا صراحة أحب أشكر جميع الحضور، جميع الحضور الكريم. Our distinguished speakers, okay, the national, international, who really they made it يعني from across the globe, the whole organizing committee, okay, the whole scientific committee, the elite of critical care from speakers from Saudi and outside, and all the our scientific collaborators, our vendors, the great partner of success who really have a great booth and a lot of support from long time ago.
المؤتمر كان في جدة ورجع لجدة، والحمد لله حضور مشرف وحضور جميل بقادتنا في التخصص بكل الطلاب وبكل الحضور من كل المستشفيات. أشكركم جميعا على حضوركم اليوم، وإن شاء الله تستمتعوا بالمؤتمر. عندنا أكثر من 100 متحدث، 15 انترناشونال متحدث، كان عندنا 10 ورش عمل الحمد لله كلها ناجحة في جميع التخصصات، وعندنا أكثر من 90 محاضرة وأوراق علمية إن شاء الله حتقدم في المؤتمر. فإن شاء الله بإذن الله تستمتعوا بالبرنامج حقنا ويديكم العافية. مرحبا بكم في جدة.
أهلا مجددا بعد العرض الجميل الرائع العفوي، ولو لاحظتم نتحمد بالسلامة للمصور الكبير. العفوية بامتياز، شكرا لكم. حضورنا البهيج، ننتقل الآن لكلمة راعي هذا المحفل. يتفضل سعادة رئيس مجلس إدارة الجمعية السعودية لطب العناية الحرجة الأستاذ الدكتور عوض بن عبد الله العمري.
السلام عليكم أصحاب المعالي، السادة الحضور، نتشرف بتواجدكم في المؤتمر العالمي 13 للعناية المركزة، والذي تقيمه الجمعية السعودية للعناية الحرجة. لقد قامت هذه الجمعية الفتية بسواعدكم منذ أكثر من 16 عام، وقدمت الخدمات الجليلة للقطاع الصحي للمملكة العربية السعودية، ولكن هذه الخدمات تقاس بعقود من النجاح والإنجاز حتى تبوأت مركزاً مهماً بين الجمعيات الطبية والخيرية. السادة الحضور، لقد أثبتت جائحة كورونا مدى أهمية العناية الحرجة في خدمة القطاع الطبي، بل وكان هذا التخصص هو العمود الفقري لكثير من الأنظمة الصحية. ونشكر لجميع الممارسين الصحيين وأنتم في المقدمة على تضحياتكم وجهودكم الجبارة للقضاء على الجائحة، فشكراً وشكراً وشكراً من القلب. السادة الحضور، لن أطيل عليكم، ولكن قبل الختام سوف أوجه بضع رسائل. الرسالة الأولى رسالة محبة وشكر وتقدير للجنة العلمية والمنظمة بقيادة هذا الفريق المتألق الذين عملوا بجد واجتهاد لأكثر من 6 أشهر للظهور بهذا المظهر المشرف، فشكرا من القلب. الرسالة الثانية لشركاء النجاح، يوجد لدينا أكثر من 16 شركة راعية وأيضا للشركة المنظمة، فنقول لهم شكراً شكراً شكراً، فأنتم وقود المؤتمرات العلمية، وبدونكم لا نستطيع التقدم كثيراً، فشكراً من القلب. الرسالة الثالثة لهذا الجمع الغفير، للمتحدثين، للضيوف الكرام، للممارسين الصحيين، ونقول لهم استمروا في بذل المزيد والتضحيات، فالجزاء من الله سبحانه وتعالى سوف يكون جزاء وفيرا بإذن الله. ختاما، لن أطيل عليكم، ولكني أقول لكم دائما القادم أفضل، ومن نجاح إلى نجاح، ونراكم بإذن الله تعالى في العام المقبل في النسخة 14 بإذن الله تعالى.
شكرا لكم سعادة الأستاذ الدكتور عوض بن عبد الله العمري على هذه الكلمة الضافية. ونبدأ الآن بفقرة التكريم، نبدأها بجائزة التميز في التعليم الطبي لطب العناية الحرجة. يتفضل سعادة الدكتور محمد بن عبد الله السلطان. جائزة تأسيس المجلة السعودية لطب العناية الحرجة والإشراف عليها. يتفضل سعادة الدكتور عباس بن صالح المطير. نبدأ الآن بتكريم الرعاة الماسيين لهذا المؤتمر. شركة فيليبس. شركة MSD. شركة بروميدكس. تتشرف اللجنة المنظمة لهذا المؤتمر بتكريم راعي المحفل سعادة رئيس مجلس إدارة الجمعية السعودية لطب العناية الحرجة الأستاذ الدكتور عوض بن عبد الله العمري. نستأذن جميع المتحدثين بالصعود إلى خشبة المسرح لأخذ صورة تذكارية بهذه المناسبة. All the speakers come to the stage to take the photo. شكرا لكم حضورنا الكريم على تشريفكم هذا المؤتمر، وندعو سعادتكم لافتتاح المعرض المصاحب في القاعة المجاورة. والسلام عليكم ورحمة الله وبركاته.
Assalamu alaikum wa rahmatullah. Good afternoon, everybody. Welcome for the lunch survivors. Of course, usually after lunch we have this reduction of people, but that's okay. I'm Dr. Walid Al-Yafi. I'm happy to present our next speaker for this afternoon. For this session, which is called the Gadgets in the ICU, before I move further, let me have a quick survey on the people here in the audience. How many of you can imagine yourself today working without a pulse oximeter? Can you put your hand up? We can give away our pulse oximeter. Well, only we have 2 or 3. And one of them, of course, is from my age group. I'm asking this question because I was a resident a while back, not too long ago, but when I was a resident, I presented a paper about this pulse oximetry, the calorimetric monitor that will look into the oxygen saturation. At that time, to have an oxygen saturation, we used to have a blood gas sample, and then we have to call the chief pathologist to take a permission from him to give us what is the oxygen saturation of this sample. That was how far that we have to go. And I presented this paper in the Journal Club as a resident. And 2 of my senior consultants, they said, oh my God, this is another toy to play with. Just forget about it. It's not going to happen. Just keep your eye on the blood. I'm an anesthetist, by the way. Keep your eyes on the blood and look for the blood when it becomes black. And that's as far as you want to know. But nowadays, with that little toy, none of us really can proceed. I'm sorry to take that long, but I think it's very important to remember that technology is important for all of us. So I'll take the chance now to present my colleague, Dr. Ismail Kashmig, who's known in Jeddah very well. He's a consultant in King Faisal Specialist Hospital in Intensive Care. He works with ARDS, MERS-CoV, COVID, and he's an expert from so many aspects. And I'll leave that for him to tell us about the use of the telemedicine in intensive care. Dr. Ismail.
Good afternoon. Thank you, Dr. Walid, for your introduction. And I think going back to your old days and looking for the future, I think we're going to come to avatar period where a lot of things will be virtual. I just, while in a break, I watched a video from MIT Technology, and they presenting just a robotic arm to take a blood and sampling with 100% accuracy for that. So I think we're moving toward that area. So not to take long, and good afternoon all. Thank you for, I would like to thank I think the organizer and Dr. Wael and Double Wael for their tremendous work حقيقة to bring this conference alive. And so I'll talk about tele-ICU effectiveness in critical ill patient, and we heard this morning from Prof. Asiri about our experience or ongoing experience in Saudi Arabia. I have no conflict of interest in related to this subject. And as we know that I think the technology advancement make even our population getting older and people seeking the medical help more. And I remember here in Saudi Arabia, and we know that probably all in Europe before, but in Saudi Arabia that in old days people when get sick at home, the family, they accept their illness and they leave it there without seeking medical help or taking to the emergency department. Nowadays we're seeing an elderly with a 90 years old coming with pneumonia and the family demanding that to receive the full care, intubation, and if require ECMO, or even if they require an invasive aggressive surgery, they still demand with that. So we're moving that elderly people with a complex population, complex disease, and advancement technology allow us to recognize a lot of disease not known before. There is a huge gap in between the presence of especially critical care team, nurse, physician, RTs, and that based on the, as a specialty is not a popular. In the same time, the iteration of the MD and RN and RT that will make them probably the number of physicians to the patient is getting less and less. COVID-19 provide for us a stark reminder for the technology. And I remember that in start of the COVID-19, the Microsoft Teams application that have probably 30 million members, and after January starting from the COVID-19, the members or the people increased from 30 million to 300 million for that. So it's just moved us toward that era. The telemedicine growth expected a rate of 20% annually from 20 to 26. And this evolution of technology also have to bring us a reminder and that we're still a human, and that movement from bedside to bedside to have put a question about it, how much we need to use the technology for our patient care. Just quick definition, there's a difference between telehealth and telemedicine. Telehealth involves administrative, education, and plus the patient care support. Telemedicine is pure clinical service. This is the polio pandemic areas where the iron lung was started at that time. And imagine at that time that this is the way that they were in the ICUs and ventilated the patient. And this is the future, as Professor Vincent mentioned, that the 10-point for the future of the hospital. I'll just quote that telemedicine, artificial intelligence, and I'm sure that he's going to talk more about it in his presentation. Robots will be more presented and visible. Hospital and home care continuation. All these need to be sure that we have appropriate network and care that to be sure this patient receive the care that they have perceived. So if you look for the starting the adoption of the telemedicine in United States, most of the data is coming from United States because I think they have the majority of the technology used there. This is the published articles by Canital. They look for 4,760 hospitals, and at time of the start of the survey in 2003, there was only 5 hospitals that they adopted telemedicine. By 2010, from 2003 to 2010, there were almost 218 hospitals they adopted, incremental by 4.6%. And this incremental mainly is happening the first 5 years. And this just tell you that it's not easy to re-engineer the system in the hospital if you move from to such a technology. Early systematic review, and I'm gonna just review a few articles to tell you that there's a quite variable on the literature between the positive impact and probably no impact from this technology. This is the systematic review and meta-analysis by Young, published in Archive Internal Medicine. It looks for around 35 ICUs included in these articles. And interestingly, that they showed early that the reduction in ICU mortality and reduction in ICU length of stay, but this did not translate and demonstrate it for hospital mortality and hospital length of stays. And probably that because the heterogeneity of the population, heterogeneity of ICU technology, and also the tele-ICU's multifaceted process is not just a single, it's not just a device or machine that we're looking for they intervene or to bring the care to the patient. Also, this is a study that was industry funded and initiated project. From Toronto, Canada, the Willox and Neil, they also look for their 11 studies, 50,000 population, and they shows there is a demonstrated also an effect of the mortality benefit and length of stay. But when this translated to subgroup analysis that were the continuous patient monitoring versus just a consultation surface did not represent it very well, and I think that because the sample size was small and underpowered for that. Same at in JAMA, Nasser et al. In Network Hospital with a 7 hospital. They look for also the length of stays and ICU mortality did not demonstrate it very well, and they even at that time they look for how re-engineer the system for the most required at the hospital to get a benefit from that technology. Later on, Lely et al. Published in JAMA his data about 7 ICUs in 3 medical, 2 surgical, or 3 medical, 3 surgical, 6,290 patients in 824 academic centers. And it demonstrated that by looking without an adjusted analysis, there was a decrease by 20% in mortality and 30% length of stays in ICU, and there's 80% reduction in side effect and complication that will be preventable by using the tele-ICU. And when you look for the bigger scale, in a multi-centers and published again in the CHEST by calling re-engineering adult critical care, he enrolled around 118,000 patients where from 56 ICUs in 32 hospitals, 19 US healthcare system and network were included. And it also shows that the mortality, ICU mortality reduced by 26%, hospital mortality reduced by 16%, in the same thing, ICU length of stays and hospital length of stays reduced between 20% to 15%. But the point to consider that to give this kind of significant change and reduction, that the intensivists were available within an hour to review the case. And I think that Dr. Prof. Asiri that mentioned that their availability of intensivists to review the case on the spot, timely use of performance data, adherence to ICU best practice, where they put a guideline and checklist for that, and the quicker alert response time for the patient condition change, that where they quickly, because we know that our ICU patient is dynamic, and they change quickly, and sometimes they call our ICU patients like a stock marketing. They quickly change, and their care during the days can be hectic from the start of the shift to end of the shift. And they look further that between that the decision-making authority or just making a recommendation for the, when you use the telemedicine technology. This is the 20 studies that included 477,000 patients enrolled in these studies. And it shows that if you make a decision level, the decision-making authority at a level of authority was associated with significant reduction in mortality in comparison just to expert teleconsultation. That means when you move further to make a decision about which treatment you would like to use, inotropic support in hemodynamic or even in a ventilator setup, that shows it's much different and reduce mortality comparing just a consultation and we'll say we recommend this one and we recommend this one and if that implemented in the site or not. This is an effect of multi-site, and after that they move to look for, they move into technology toward the multi-site kind of telemedicine program, and this is the first time they create what you call eICU. And that's become a trademark for one of the unit there. So the remote program and intensivists, they look for to monitor the patient in this unit from noon to 7 a.m., where this is an academic center that they have academic intensivists. They mainly involved in education and academic or intensivists in service. They work until noon time, and they use them for consultation for that. So they look for this population, and definitely they shows that there is a difference in a mortality between the pre-intervention group and post-intervention group where they involve what you call eICU. CANITAL, it looks for the national effectiveness studies at the United States, and they enrolled around 132 hospitals where they have an intervention, they call case hospitals, and 389 control hospitals. They don't use the telemedicine group, and they shows that significantly that there is a reduction, a small, statistically significant in 90 days mortality for those who have the case hospital. Only 16 hospitals, around 12% of this hospital had a statistically significantly reduction in mortality comparing to all. So this is a small numbers compared to whole the case that or the hospital or case hospital was enrolled in the studies. And there is definitely, they were urban hospitals and with a higher admission rate, more than 10,000. This is a point that where it's run counter to expectation that the tele-ICU most benefit a small rural hospital where the care expertise is limited or absent. And it shows that once the number of the patient admitted is higher, the benefit is getting better for these patients. The financial issues is a big issue, and I'm sure that it's, the money is important for all the hospitals, and especially for the manager executive that when you introduce a new technology, would like to see the cost effective and benefit from that. And it shows that definitely if you look for the literature on the telemedicine and a financial outcome, there is a variability between the positive impact and saving dollars or reals or euro, comparing to that it's more expensive and not cost effective for patient care. Sorry. Okay. This is the studies that also published and look for a specific group of the population. And if you generalize it, that means if you include every patient, you not get that benefit from that. And this one, that in 6 ICUs at 5 hospitals, and for non-for-profit healthcare system, they enroll around 4,142 patients in a 33 tele ICUs and 2,000 around in post-tele ICUs. Interestingly, the most benefit of the tele-ICUs, it goes toward that when the severity of scoring system, they use the SAPS-2, is more than 50, with also cost-effective in a selected group of this population, so that if you use it in the less severe patient, you may not get the benefit and not cost-effective. If you move toward that more sicker patient and a severe illness, that probably you may save a cost for the patient, at the same time reduce the mortality. And this is a clinical, also economic outcome studies did not demonstrate that the same result that demonstrated in the previous studies, although it shows there's a variation between in the same hospital between a reduction of the cost to increasing the cost based on the implementation of the technology, patient care, and also the outcome of the patient and the length of stays. One of the important things also used that in telemedicine, they use it to prevent complication adherence to guideline. And this is demonstrated with the Craig Lally in JAMA 2011, shows that using a tele-ICU intervention period, use a tele-ICU intervention that they have associated with a higher rate of best clinical practice adherence. For example, longevity, prevention of stress ulcers, prevention of the VAP, lower rate of preventable complication by just using the tele-ICUs. And also additional data shows that telemedicine around successfully performs improvement strategy for sepsis management and the adherence to the bundle and guidelines. And this is the studies also retrospective studies looking for the data between 2014 and 15 in one ICU center with one hospital with 3 ICU at Germany. And it looks that in daily round with a routine screening for the sepsis was conducted, and it definitely statistically shows that the compliance to 3-hour bundle, compliance 6-hour bundle, and mortality was significant in the group where they have an intervention with the telemedicine. This is a nice studies done from the Brazilian group during the COVID-19. And we know that all the shortage during the COVID-19 for the intensivists move us toward such a technology for that. But interestingly here that they know that the ICU population is still the tying to or following the ARDS network guidelines, and the low tidal volume compliance is low. This shows that by using telemedicine, there was a provision trained to standardize the care of low tidal volume in such a population for that. So we have evolution moving from tele-ICU to tele-critical care, where is a package that including not just a technology, it's a system, it's a huge system, and Prof. Asir demonstrated that in what we're doing in Saudi Arabia. So this is the evolution, moving from tele-ICU, telemedicine, tele-ICU to tele-critical care. And it's very important that it shows that also the families, if you ask their opinion and they inform them, they have a good percentage that they like it, because they think that there is another, let's say, second eye to look for their loved one. In the same time, they think that there is an expertise ideas is coming for such a patient. So we call it patient beyond the walls, and the technology is variable between the centralized hub and spoke program to decentralized program to hybrid program structure. Each one have a pros and cons. Each one have its need and strategy, and it require just, what's the best suit for the institute for that. This is the survey done by Society of Critical Care Medicine. They look for response from 561 unique center. Only 35% of them, they have a unique or what you call formal critical care program. 65, they use a phone, they use a FaceTime, they use a different technology, reviewing the radiology and an extra for that. And at the same time that they 70% use, they identify emergency patient problems, 55 provide a continuous monitoring, 30 use educate and provide an educational for the ICU staff, and 25% they practice daily care planning mentorship. There is a variation, so there is the continuous care of such a patient is variable in the literature for that, even on the ground. So bedside to website, is it a new norm for our critical care future? Could be. We may have in credentialing e-intensivist, ERN, registered nurse, respiratory therapist, e-pharmacist. That's something we may look at it. But it never been replaced the physician. I think this is very important, and Prof. Vincent mentioned that we still need a human touch for the patients. It's not just a technology. I think that's very important to understand. It's never meant to replace the patient care by the human. The technology itself cannot change the outcome at all. So the barrier and challenges, there is a lot of barrier and challenge. Cost and return of the investment is very important. I said that each administration look for what's the return on investment. There is organizational human factor impacting tele-ICU effectiveness, and this is demonstrated all the studies. In CON studies, there's 12% decreased mortality only in all the studies, 81, no change at all. And that tells you that there is a multifaceted factor that impact on such a result. 24-hour coverage versus weekdays, night, or just consultation. Very important, the staff acceptances and skepticism about this technology. It's very important that you have this staff inside the ICU, they accept such a technology and collaborate hand-to-hand to provide the best outcome. Credentialing, legislation, the licensing is very important. Either we go to underutilize such a technology. If you put a 200 million riyals and you not utilize it in a right way, that's a waste of money and underutilized authority. Or diffuse responsibility is another issues for that. Standard of care in interconnected world, we know that still there is a controversial about the standard of care. We agree in some of the disease in standard of care, but there is a huge list in our disease and critical ill patient. We don't have a standard of care for that. technology malfunctions and issues as well. So where's the future and what is the, what's going to happen? I think very important to have a rigorous comparative research need to support it. I think we have to be sure that if we design such the technology or program, it should suit the department very well with the cost and revenue and at the same time with a good outcome. So I'll come in the end. Conclusion that the benefits of tele-ICU have not been uniformly positive, as we see that. Still there is a variation on the outcome and length of stays and saving and cost for that. Although telemedicine is understood to be potentially effective tool and adoption is increasing rapidly, high quality data concerning effectiveness, costs, and acceptability by ICU staff, patient, and career remain limited and deficient for that area. Still that we need a lot of research in that area. Giving dual need improvement to ICU outcome and reduce cost is essential that we target new technologies, and the new care model should benefit to the hospital where they benefit from that. And there is, as I said that, sometimes we go, introduce a technology in the area that probably is not to get a benefit from that, and just a waste of resources and money as well. The ICU telemedicine proved to be invaluable and likely to the key feature of the future of critical care medicine. Thank you.
Assalamu alaikum. Second speaker, my pleasure to introduce Dr. Maha Al-Jaid. She is the Director of Clinical Nursing for Ambulatory Care and Hemodialysis Center at the King Abdulaziz Medical City, Riyadh. تفضل دكتور.
Good afternoon, everyone. Assalamu alaikum wa rahmatullah. Thank you for the Saudi Critical Care Society to give me these opportunities to discuss a topic that it could be not easy and more technical, but I'll try to make it interactive as much as I can. So when we talk about technology into practice, it's not something new. The technology have evolved in critical care, and now we are even reaching to a life that digitalization is all around us. Our home are smart, our phone are smart, our hospitals are smart. So digitalization integrated into human life currently. So I'm going to talk about a little bit of historical background, technical terms, and then we will differentiate between innovation in healthcare and technology. What are the motives and barriers? How do we sustain innovations? What are the guidelines from the WHO, as well as the step to ensure safety of patient and provider while utilizing technology? Then we'll put some recommendations. So historically, the first integration of software as IE or artificial intelligence was in the last century, as where basically Arthur Samuel, one of the coders in IBM technology, he created the first artificial intelligence as a game that can play against opponent to human being. Then telehealth perception started to increase in early 60s, and the modern telehealth that we know and we practice currently started in the 1990s. In 1972, the first diagnostic system utilizing machine learning created in UK, and then in 2004, the European Union gave the e-commission or e-health improvement access to healthcare, where they mandate the European Union state members to integrate digital competence and digital transformation into healthcare system. So what is the difference between innovation and technology? Innovation is basically utilizing pre-existing information in a new context or in a new format. WHO defined medical technology as application or organization of language and knowledge and skills in order basically to develop and improve the quality of life and safety of the patients. So the digital transformation is more into organizational perspective, where basically the entire healthcare system utilizes a framework to address challenges in care practice. And one of the classical examples of digital transformation was, for example, Tawakkalna during the pandemic. The system was smart enough to detect potential cases and infectious cases, and the color automatically changed, and people are mandated to stay in lockdown. The digital competence, therefore, is basically the ability of providers to utilize information system technology and communicated them through utilization of internet. So we use artificial intelligence in our daily practice, and we use virtual reality in daily practice. So what is artificial intelligence? In simple terms, artificial intelligence is a human intelligence exhibited by a machine or a device. Where machine learning is basically the machine is smart enough to learn from the experiences and applications of analyzing of stored data to better performance. One of the best examples that we are using for digitalization and artificial intelligence in our daily practice is the infusion pump, as well as the FDA also approved for pharmaceutical companies to utilize artificial intelligence to basically analyze algorithm and study drug-drug interaction and drug toxicity, and instead of waiting to animal tests that could take decades. So we as healthcare professionals, we make decisions based on the data that we receive, either from imaging, from monitoring devices, or from lab data. We should have the ability to apply this information in order to make a diagnosis and implement interventions to our patients. Our dear doctors here, he explained to us the difficulties of utilizing pulse oximetry, that it's now simple and basic even in out-hospital setting. Patients can measure their autosat at home. So the diagnosis accuracy of artificial intelligent medicine start to improve, and where we have machines that can basically analyze CT and analyze lab data and give an early diagnosis to the patient, which basically facilitate a clinician's time and help them to make a precise decision related to managing their patient. So the good performance of artificial intelligence require also a good attitude from healthcare provider, or positive attitude toward utilization of technology. So why do we innovate? Do we really need to innovate in healthcare? There are a lot in the market already. Yes, we need to innovate because patient complexity is different, our interactions with the machine are different, and the future of healthcare system start to be reshaped massively. So innovation helps us to improve our outcomes, reducing cost, enhancing patient experience, as well as effective utilization of healthcare resources. So any organization system that would like to purchase a new machine, they will think about the 8 dimensions of these innovations. So the company will share their opportunities to explore ideas, what are the clinicians need in the market, then they go and they basically manufacture these devices, and we as end user, we have to pilot these devices, then we adopt this technology, and subsequently we became even advocate to utilize this technology in order to maintain our patient safety. A classical example is electronic health record. Now, most of healthcare systems are utilizing digitalization and automation of order in order to avoid errors. For example, the system of automation of electronic health orders will help us to prevent prescription error, as simple as that. So we utilize artificial intelligence on a daily basis to maintain patient safety. So what are the motives and barriers? Dr. Bushmaq has mentioned some of the motives and barriers to technology integration. One of them is basically the organization vision to digitalization. So utilization of digital transformation, it has to be a vision of an organization in order to proceed with it. But the organization to promote technology integration, they have to provide resources that are training of their manpower staff, coaching and supervision of utilization of this technology, monitoring of technology application on patient outcomes, and most importantly, giving or supporting the workplace environment in order to achieve a positive attitude toward technology. So to sustain innovation, what do we need? In order for the innovation to be diffused within the healthcare system and communicated through different layers, we need a partnership between academia, technological industry, and clinical settings in order to facilitate utilization of these machines in daily practice. The WHO tried to govern this process, and they published their recommendation guidelines related to digital health. So basically, they consider that implementation of digital health system intervention is a very important tool that healthcare system can use, help them to address challenges in access to care, help them to improve solving problems that we see in daily practice in critical care as well as in practicing clinical care in general, especially if we have a limited resources or a limited access to care. Telehealth is a perfect example of improving access to care in a remote area through e-consultation and e-referrals. So the WHO's, okay, sorry, how I should go back, yeah. So the WHO worked collaboratively with the International IT Union to basically give e-health toolkits that will help organizations who are trying to transform and digitalize their system. That include availability of IT infrastructure, availability of trained healthcare workforce, as well as policy to govern utilization and privacy of these data, financial resources, and most importantly, standardization and policy to ensure safety of these technology and system. So is technology integration in clinical care is good? Yes, it is. It helps us to basically have more diagnostic accuracy. It optimizes patient treatment plan. It gives us a real-time data that minimize and guide our interventions. And also, it gives us an anticipation of patient outcomes, and therefore, it helps us to improve patient and family experience. And nowadays, in technology, healthcare companies are more smart to integrate different parameters in one small screen. So no more bulky ICU with hundreds of devices where you can't see the patient. All what you see is different machines, and the patient, if they are awake, they are scared. The family, when they visit, they are scared. So now we are moving into more friendly ICU, and digitalization help us to utilize and achieve more friendly ICU to our patient. So what is the bad in merging technology with the practice? The bad thing is these devices, they need calibration, they need IT support 24/7, they have alarms, sounds. These alarms and sounds cause alarm fatigue, so the nurse could stop the monitor alarm just because they were already fed up from the beeping of these devices, although this beep could be an alarm for a critical situation. We could have a poor interface or poor design, a system that is too complex, or a Wi-Fi network that are too bad, and this will give frustration to care provider to adopt this technology. Lack of digitalization competence, so organizations that think about digitalizing system, they should have enough resources to train their staff and enough technical support to support their staff. Obstacles in digitalization include also different interests between stakeholders. So clinicians, they want systems that are user-friendly, that is system that is accurate, and in a small clicks, we will have data, as well as systems that are compatible with devices that are already existing in the clinical units. So what is the bad thing about utilization of technology and the ugly thing about it? So the ugly thing about it is basically we as a clinical provider already live our life in a digital era. We over-rely on the machines to the time that we forget to treat patients and we start to treat numbers. And it's really important to understand that no matter how much smart system you have, the smartest system you have is your hands and your observational skills to assess those patients and raise suspicions of their changes. So the other issue is with the transparency and privacy of the data, also storing this data and sharing them. So we should have a clear policy to restrict data sharing and accessing of patient information. I remember during COVID, we have a very limited restriction on utilization of electronic health record. And in the initial cases, when any staff is COVID positive, almost entire hospital, they know that X or Y is COVID positive. Again, lack of privacy is an issue. So what are the safety steps in integration this technology? This technology helps us also to promote patient safety. So the electronic system alert, initiated basically to guide us when we are processing an order that this order may be potentially wrong. It gives us a reminder that provides us essential information before order entry or order process. There are different safety stops, either soft or hard. So the soft stops is basically reminding the clinician initiating an order that could be potentially harmful interventions where the provider only have to acknowledge and proceed, or hard stop where physically the provider is entering wrong orders and the system will prevent the provider from continue ordering process. So we see monitoring devices that are bulky, that are difficult, and we see monitoring devices that are smart, like the hands-off monitoring system. So where basically if you are dealing with patient who is infectious, the monitor device is like an iPad screen, and it has all the information, including environmental safety for your patient and precautions. So you don't even need to touch. So that's one of the ugly side as much as its positive side, because that means some clinician would refuse to go to the patient and will just treat the monitor data. Telehealth was explained in detail by Prof. Asiri and Prof. Khushmaq. However, we just have to highlight again that telehealth, especially during the pandemic, it's accelerate the way care providers start to deal with their patient. It provides e-consultation to remote area, access to expertise for the patient while they are in their home and treated safely. It was widely used also during the pandemic in stroke care to care for those patients who are stuck at home because of the lockdown. One of the very common technology we use in our daily practice is the point-of-care testing. There are a lot of evidence in the literature supporting utilizing of point-of-care testing for many reasons. Accuracy, it doesn't require special training, it doesn't require lab technicians and bulky devices. However, monitoring technology of point-of-care testing now moves to our home, and thanks to advanced technology that these sensors are now, it's like your watch. You just put it in your skin and it's analyzed and give you the data, and you basically text your result to your care provider through a smartphone apps, and they will recommend you what to do. So there is a form of patient empowerment and self-management for their symptoms and treatment. So in order to integrate technology, we should look at their efficacy, and is it visible to use them in the clinical setting, yes or no? So this is my last slide for the recommendations. Healthcare providers utilizing digital technology on a daily basis, so therefore they are mandated to be competent in information technology system. Organization systems should support their staff by creating positive environment and training modules for those staff to utilize technology, and ethical policies and consideration are essential for caring for patient utilizing digitalization system. So regardless of technology you're gonna use, it's focus on three things. To sustain technology, you need a teamwork, a stakeholder engagement, including IT and clinicians, organizational strategy and culture that to promote digitalization, and to keep your patient care in the center to facilitate their care. So we as healthcare provider, we are champions of utilizing technology. However, we have to make sure that these technology are in favor of our patient outcomes and to enhance their safety. Thank you so much.
Thank you very much, Dr. Maha, for keeping with the time. I know that we're pressed hard to the time. Our next speaker does not need the reintroduction, Professor Vincent, who has presented this morning about the future of intensive care and medicine, actually. And now he's going to tell us about the artificial intelligence that you're going to hear from him. By the way, he's an editor of an encyclopedia in intensive care. So whatever you read, you hear from him, he is the one.
That's the truth. Thank you. Yeah, thank you. I'm enjoying this session. It's really interesting to speak about the future, and that's what I will do as well, because artificial intelligence, of course, is a technological development, which is nothing else than a sophisticated computerized system with also sophisticated statistical analysis. That's the road to innovation, because exactly as with internet, our world will change with artificial intelligence. We may like it or not, that's the future. And we will like it, I'm sure. Actually, it started not so long ago, in 1950, when Turing proposed that we could use computers to go one step further. And that was the beginning of artificial intelligence. And as we know, later machine learning came, and then deep learning. It's increasingly sophisticated, because machine learning is the next step when the machine starts to develop programs on its own, doing better than just what we gave to the computerized system. And then deep learning reproduces our brain thinking with several layers. So it's becoming increasingly sophisticated. Artificial intelligence, in my mind, should not become better than humans because we want to keep control. But it can go faster than our brain. How many horses with 3 legs? Can you tell me? Of course you can tell me. You will look at it, it will take 15 seconds, and then it will say, yeah, I can see 4. Well, did you look at this one too? Yeah, it should be 5. Well, did you notice that one tail is, oh my gosh, yeah, I didn't see that one tail is missing. The computerized system will do it in less than 1 second, of course. I find this interesting. I looked at it for a long time. Do we have 4 bars or 3 bars? What would you say? Very difficult, very difficult. I don't know. I don't know what the right answer is. That's a frog and that's a horse, right? No, it's the same thing. No, it's the same thing. Look at the frog, look at the horse. No, it's the same thing. Oh, I thought that these were different animals. But the computerized system will say, no, my friend, this is exactly the same image. Now, the computer will also get things wrong. In our field, the best example is patients on vasopressors are more likely to die than patients without vasopressors. And there is no big difference in blood pressure, in heart rate. So, let's the disease, very important, with alarms. Diagnosis, it's quite well known, and we could go into a different field. I mean, you may have this app on your smartphone, as I do, when I look at a flower or a plant, boom, and I can see, oh yeah, it is this or that type of flower or plants. But of course, it can be done in dermatology. We could send the image to a dermatologist and say, oh, what's this? And the dermatologist, with good cameras as we have today, could actually help us. Now, if we do it with the machine, we could tell the artificial intelligence system, that's melanoma, that's no melanoma, that's melanoma, that's no melanoma. A good dermatologist could feed the system. But at some point, machine learning will come into play, and the artificial intelligence system will start to actually improve the recognition of skin cancer by integrating this additional information. And again, initially, it should be validated, but at some point, the computer could go on its own, and the doctor would no longer have to check it. We already have our EKGs analyzed automatically. Initially, we had to supervise it make sure that the interpretation is correct, but now we trust these analyses. And then, of course, it can go into neural networks in a much more sophisticated process. If you think about it, a mammogram looked at by a radiologist, what does the radiologist do? The radiologist just has a reasonable algorithm in his or her mind. Why can't the machine do it? Of course, could be done. And from there, we can go into therapy. This is a very good example. The prescription of antibiotics. What is in our mind when we prescribe antibiotics? First, of course, we need to have a suspicion of infection, obviously. But then we take into account the microbiological information, if we have it, the source of infection, the allergies, the hospital ecology, the local policies, the cost, and then we go ahead and we decide to choose antibiotic with the doses, the route of administration, etc. It's a very logical process. If you call an infectious disease specialist, the infectious disease specialist will go through the same algorithm. So, yeah, that's been put in a computer in the last century, in 1998, in Salt Lake City, where they have always liked these new technologies. So it's not something so new. We will need less infectious disease specialists to help us in selecting the antibiotic or the antibiotics for infection. And if we think about it, for any diagnosis, what do? We integrate the information, the history, clinical examination, additional tests. We say, it's probably this. We may need some additional tests. Yes, the artificial intelligence system can help us not to forget anything and can say, why don't we add this or that test? Shall we get there? Sure, I don't see why not. I don't see why not. During surgery or during a procedure, the artificial intelligence system right now can already guide the doctor in his or her resections. Take a bit more out. No, that's enough. So that's the kind of application which is already there today. This slide comes from a very famous center in Strasbourg in France. Now, prevention or the evolution of a patient, this is something that we touch on this morning. Right now, with our rapid response systems, what do? Oh, the patient has a fast respiratory rate, a fast heart rate, a low blood pressure. I mean, we use this kind of Muse scores. Nurses can use it, and they call the doctor. They say, oh, the Muse score has increased by 3. I need to call you. It's a way to objectivate the clinical abnormalities. And then on some wards, like here in South Florida, the nurses could see which patient is likely to deteriorate because the image is moving in one particular direction. Interesting, yes. That's indeed something of importance. And then it goes into a central station where they can look at it and say, oh, the patient there in the bed 321 is likely to deteriorate. And there are Rotman scores, there are some various systems that can help to identify the patient who may become in trouble. Now, we touched on that this morning when we spoke about the future of ICU. It's not only pulse oximetry that we have as a monitoring system. It could be nasal capnometry, so that we have some information about PCO2, or we could also monitor the ventilation on the regular ward, or we could even monitor respiratory rate by acoustic monitoring. or plethysmography, or a mask with a sensor. Yeah. So it's quite easy to monitor it. During the COVID crisis, we developed these wireless sensors, just hearing the gas moving in and out of the larynx. And this is without discomfort for the patient. We can put a sensor under the bed and have heart rate. We could have a camera, as we do have in airports, that could identify the development of fever. We can do it in airport, why can't we do it in the hospital? And we no longer need the central station. There may be a problem of alarm fatigue if the alarm goes off too often, but if we think about it, many abnormalities come together. If there is a fall in SpO2, there is usually an increase in respiratory rate. There may be an increase in expired PCO2. If there is fever, there is usually tachycardia, and there is usually tachypnea. So we could have combined alarms, and it could go directly on our smartwatch so that we prevent the problem by intervening earlier. We could actually then ask for the control CT scan, or we could call for the surgeon to come back at the bedside and re-examine the patient with us before the patient goes into a critical condition. Does it work? Yeah. We can even add some additional data if we deal with sepsis. We could look at precise trends in blood pressure. This paper shows it very well, the path to precision in the ICU. Or here, Dr. Liu and collaborators recently published the results of a hospital-based system that worked pretty well in identifying sepsis with a decreased mortality rate when the system was implemented. Isn't it logical? Yeah, that's the way to go. And this paper is also very interesting, showing how complex this may become. With the machine learning system, deep learning, now we can have very sophisticated problems. Actually, very sophisticated analysis. Actually, artificial intelligence is particularly interesting when we deal with multiple variables. This is an artificial intelligence system developed in Australia to identify in crowds patients who may be ill. And of course, it was done during the COVID-19 crisis. So you can identify the patient who may have fever and cough and have tachycardia. So isn't it nice as a way to screen populations? If we speak about digital nutritionists, we have so many negative studies in nutrition because, again, we do not individualize our decision process. But if we do, we could actually integrate a number of elements. And in the perioperative care, it's also quite clear. And so there are simulation centers taking care of all that. So very briefly, I told you I would return to endotracheal intubation. When should we intubate the trachea of a patient who is in trouble? We don't want to do it too early, but we don't want to do it too late. So what do we do as good clinicians? We look at the patient, we look at the respiratory rate, we look at the way the patient talks, we look at the neurological status. You know, I have insisted in the Surviving Sepsis campaign, I said, we need to give some recommendation to the young physician. We are here to write guidelines. When should we intubate the trachea? And my colleagues and I here in this recently published paper, we said, okay, you need to look at this and that and this together. Perhaps it's not that simple. No. You and I, we may say, okay, that's the reason why we need to have a good doctor at the bedside. But how do you do this? How do you integrate all this? And the computerized system, the intelligent system, could take into account
the respiratory status, the hemodynamic status, the neurological status. And actually, it's a very good setting where artificial intelligence could really play a role. You would not intubate the patient who may have a transient hypoxemia, transient ARDS, as shown here in the Schenk study. There are some patients with ARDS who will do quickly better. Perhaps we could continue with non-invasive ventilation, non-invasive support in these particular patients, but we need to identify them correctly. ARDS management. Oh, low tidal volume. What do you mean, low tidal volume? It's not 6 for everybody. Give me a break. No. It needs to be individualized. We know that 12 is worse than 6 cc's per kilogram. Okay, but what will be the tidal volume of my particular patient? Now, same thing for PEEP. Oh, PEEP, I don't know. Higher or lower PEEP level in clinical trials, no difference in survival. So, doesn't matter? Well, it does matter. Wait a minute. We need to evaluate atelectroma versus volotroma. We need to evaluate a number of variables. And we had this morning a good talk on power. Now there's the new word. Power, it combines everything. Tidal volume, the driving pressure, the flow, the PEEP, everything. Yeah, but when I'm at the bedside, I say, okay, what should I do now with this power? And it makes sense. Very complicated, but it makes sense. But that's really where artificial intelligence can come into play. We can have subphenotypes, and for each subphenotype, we could have a right way to mechanically ventilate that patient. So finally, for respiratory failure, we also need to take into account that when we increase the pressure within the thorax, there may be a circulatory impairment, as it was alluded to earlier today. There could be hemodynamic alterations because the heart now is surrounded by an increased pressure. So venous return could go down. So that's something to take into account. The right ventricle may be particularly at danger when PEEP levels are increased. So all of this can be combined in intelligent systems. With my protege, Dr. Josten, we showed that they could be closed-loop systems for noradrenaline administration during surgical procedures. But it's not just blood pressure. This paper just came out showing how we could also use fluids in the same setting and evaluate the patient's response to fluid. Because if you use only vasopressors, there may be excessive vasoconstriction. We need to maintain flow. There are many people who no longer use cardiac output because they don't know how to interpret it. But we need to take into account a number of variables together with the cardiac output. We could even visualize it at the bedside, and now we start to really understand how this works. This is also a very recent paper from people who have a particular interest in sophisticated monitoring during surgery, and you can see the patient avatar on the screen identifying the various characteristics of the patient. And that can help us to identify the best way to treat it. Remember this recent study on artificial intelligence in hypotensive patients showing that the system could actually do better than humans in deciding to give more fluids or more vasopressors in these shock states. Before going to the emergency department, artificial intelligence systems could also help in the emergency department also to know where to orient the patient. But I'm running out of time, so I will finish up by emphasizing that this is the route to personalized medicine. Because protocolized medicine, I'm sorry, it doesn't work very well. You know, now that we look at all this, can you imagine that there would be one blood pressure level as a target for all patients with septic shock? This is ridiculous. This is ridiculous. Of course, the blood pressure level can vary according to the patient. So that's how we wrote this, saying you need to individualize the blood pressure targets. You need to individualize your resuscitation. And that's your intelligence, and that's the artificial intelligence. So there are some hurdles, and I will skip them, but you know, sometimes indeed, man can be right, machine can be wrong. Facebook apologizes after its AI labels black men as primates. Very bad. Or here, they neglected information in non-white populations. So we need to be careful about all this. I mentioned Watson, which is now sold from IBM. IBM abandoned Watson. They made wrong recommendations in the treatment of cancer. So this is evolving. That's the message. You should not lose power. We should not lose oversight over the machines. Nobody is perfect, but clearly we are making progress, and this will help us in the future. Right now, the expert may be better than the artificial intelligence system, but the artificial intelligence can already be better than the young resident who has no experience and may be tired at 3 o'clock in the morning. But in the future, AI will be better and better. The evolving role of the doctors, we will have more time to talk to the families, to discuss the ethical aspect, to see what is the best for the patient. So don't worry. Someone this morning asked me, will there still be a place for doctors? Yes, of course there will be a place for doctors in the ICU, but the role of the doctor will change. We will be advisors to the patients and their families. So let's reach a conclusion. We are making progress. AI in healthcare is there to stay and will develop further. I showed you the 3 major fields of applications, and you can read further reviews or editorials on artificial intelligence in the intensive care unit. I think it's fascinating to see how we can make progress thanks to the technology. So there are future challenges, but we must embrace and engage with this new technology to improve our ability to offer real personalized medicine for the benefit of our patients. We have so many negative trials when there are prospective randomized controls. We spoke about it earlier. Now we are going into a new era where we will rediscover the personalized therapies. Thank you very much.
Last speaker, Mr. Ahmed Al-Qahtani. He's a senior respiratory therapist in Riyadh. Only 10 minutes. Where is he? طيب. Okay. So we'll close this session. Yeah. Okay. Okay. Please
Assalamu
start.
alaikum.
Okay, you have only 10 minutes, huh?
Okay. So today I will try to answer the questions. Will technology improve patient outcome, which has already been answered by Professor Vincent? Yes, it will, but now we're going to concern on automated mode of ventilation in the ICU. Now, what is automated mode of ventilations? The availability of compressor or microprocessor-driven ventilators and closed-loop control, in addition to established clinical algorithms and pathways, all these integrated will give us the automated mode of ventilation or automated control of ventilation. And this automated mode of ventilation has different level and of how much they actually control automatically. The first is the standard, which is automated maintenance of pressure and gas flow. And basically, this is classified as adaptive ventilation and very common and available in most of the ventilators in the market. The second is advanced, and this is here where we actually take or monitor some of the patient physiological data as a feedback into the ventilator, and automatically the ventilator, based on these findings and based on the built-in protocols or the pathways, this adjusted ventilator output, such as respiratory rate, tidal
Dr.
volume, and
Qahtani,
pressure support.
we need your
And
slides.
basically is
Your slides,
Yes?
please.
Huh?
We would like to share your slides with us, please.
I shared it already, it's on the screen. Share.
I'm really sorry about this. I think we have a technical error for the lecture. Unfortunately, there is a problem with his lecture, so we're not going to be able to continue his lecture. Sorry about that.
Sorry, we'll close this session. We'll go to the second session, please.
Thank you very much. So if you don't mind, we are very way far in the schedule. We will continue the next session. So the next session is going to start. There is no coffee break now. So after we'll go to the coffee break. Appreciate it. Thank you.
Assalamu alaikum wa rahmatullah. Good afternoon. I think we will resume because we're a bit behind the schedule. I am Ahmed Al-Burakan. I'm the head of critical care trauma chapter. We are proud to be part of this great organization. We're going to present some interesting topics about trauma and acute care and the setting of critical care medicine. Without further ado, I would like to present our first speaker. He is Dr. Hassan Mashbari. He's an assistant professor of surgery from University of Jazan. He's a trauma and critical care surgeon and acute care surgeon. He's going to be talking to us about new innovations in hemorrhage control. Without further ado, Dr. Hassan, the mic is yours.
Okay. Awesome. Can you share my slide, please? Right. So, good afternoon, everyone. My name is Hassan Mashbari. We're going to be talking today about a little bit different about what we have been talking about today. It's going to be talking more about trauma and about the new innovation that we end up doing to stop the bleed in an area that you cannot be able to compress or do something about it. So I did my 2 years of fellowship in acute care surgery and trauma surgical curriculum at Mass General Hospital. And what we have been doing is that on a weekly basis, on Wednesday, this is what we do. We sit down and together and talk about different research projects and actually we end up coming with very, very great topics. And I'm going to talk about two projects that we end up doing during that time. So Dr. David King, who is actually a military person, he's in the Marine, and also at the same time, he's actually the fellowship program director. And during those 2 years, we've been looking into figuring out exactly a way about for the pre-hospital EMS on the front lines, what are the things that they can be able to do to stop the bleeding while the patient not able to reach the hospital on time. So the first one we're going to talk about is something called the rescue foam. So multiple studies have been done about this, and what they end up doing is injecting this material, which is going to be talking about in details about it, in the pre-peritoneal space. So among the studies we end up doing, can we use the same material to inject it not only in the pre-peritoneal space, in actually intra-abdominal space to control two things at the same time? Control a very bad blunt pelvic fractures, plus an intra-abdominal bleed from a liver or spleen that unfortunately you cannot put a pressure on it till the patient gets to the hospital. So the first material that we're going to talk about is the pre-peritoneal. So all of you guys know that the blunt pelvic fractures with the very complex venous plexus there cause a lot of bleeding. So there's multiple things you can do. An angioembolization, there's the REBOA in zone 3 now, and also the pre-peritoneal packing. What about using a foam that you can inject it in the pre-peritoneal space and actually can stop the bleed? And that actually worked. What about doing it in the intra-abdominal space? So this material, which is called the rescue foam, it's two materials that once you combine them and you inject them inside the abdomen, it causes a transformation and a thermic reaction. That foam immediately start expanding inside the abdomen and just completely cover the entire abdominal cavity. And not only that, it's caused, number one, an increased intra-abdominal pressure. Number two, actually has a coagulation effect. And with that thing, you actually can stop the intra-abdominal bleed, give a patient time, and you can just basically use that time to get the patient to intra-hospital. And you can use it through the same way as you're doing a DPL in a trauma patient, just a small periumbilical incision, and you can actually just inject the material into that, and within a second, the abdomen becomes very distended, and you have to go to the hospital to be able to remove it. But that buys you time to get to the hospital. All right, so what are the results? So this has been, because as I told you guys, we have been doing that in the pre-peritoneal space. This paper is about the intra-abdominal space. So we already been using this material. To reach a human level, you have to ensure the safety. So there's multiple, almost more than 600 previous animal studies that has done by the same lab to make sure that whether it's safe or not, and demonstrated in paper 4 and 5 that I wrote, quoted here by the same institution, that this is safe. That's number one. Number two, I'm sorry, whether actually there is a survival benefit or not, and paper 4 and 5 prove that. Number two, is it safe or not? And actually, you can see the studies in 1 and 2 demonstrate the safety. And the third thing, how much I need to inject. And those actually done as well. And we were able to identify in previous studies since 2000 and end of 2007, 2008, this has been going to reaching the proper human cadaver dose that we can be using and safely in human. So again, we have been done this in a pre-peritoneal cavity. Can we do that in the intra-abdominal cavity? And the goal is that to show that there is no difference. And again, the reason why we have been pushing into doing it intra-abdominal, because this takes care of two things. Take care of your very bad pelvic fracture, as I said, take care of your intra-abdominal organ fracture, intra-abdominal organ bleeding. So does it give the same effect? So where we hypothesize that, yes, you give it in the and you put it in the intraperitoneal cavity, in the pre-peritoneal cavity, it's gonna do the same effect and stop the bleed, or at least slow the bleeding. So what we end up using a Yorkshire swine, and we cause a unilateral cavity retroperitoneal vascular injury plus pelvic fracture. And I will show you how we end up doing that. So we did a dissection in the pre-peritoneal space. We actually cannulated the external iliac artery and also cannulated the common iliac vein. Not only that, we cause we cause a pelvic fracture that I'm going to show you the actual instrument that we use to cause that pelvic fracture. And once we cause the fracture, we pull the wires and we pull the catheter. That cause, once the catheter come out, that cause an actual bleeding in the pelvic. So we simulated an actual, not only a bone fractures with a venous, but actually cause a main arterial bleeding as well. So this is what the machine is. Unfortunately, it's a bad machine, but that's what we use to simulate an actual AP fracture of the pelvis. And we divided these patients into three. Number one, as a control group that we just only gave them fluid, and we both these three groups we use the same kind of injury, intraperitoneal. The vascular injury and the pelvic fracture injury. So that's group number one. We only gave them fluid. The group two is the preperitoneal that we already been done study on them, and we made sure that it's actually efficacious. The three, which is the target group what we wanted, is intra-abdominal. All right? So what we do is that once we cause the injury, immediately 1 minute after that, we deploy the foam, and we monitor these swine for 3 hours. And we define the death as if the MAB was less than 15, this is by default that the animal died. And we were looking mostly into the efficacy, and it's actually comparable, and it showed the same effect if you give it in the preperitoneal or in the intra-abdominal. And this is the timeline. You can see the first thing we did is the complete vascular injury setup. You set up everything. You put the catheter. You externalize the wire. Then we caused the pelvic fracture, and immediately 1 minute after the fracture and pulling the catheter and causing the vascular injury, we deployed the foam. And we, after 5 minutes, give a 500 IV fluids, then another 12 minutes after, we give another fluids. And we looked into to make sure that we actually gonna, that this injury is reproducible, that if you looked at the parameter, that the MAP at 1 minute, it's the exact same thing, whether you are in the control group, the preperitoneal or the intraperitoneal. This, we can say that all the three groups or the three arms has the same exact kind of injury. Because if there was a defect in the MAP, let's say, for example, the MAP in the intra-abdominal was more, we cannot say that the actual injury are the same. So before we even go to the results, I want you guys to make sure that we're actually causing the same injury and we have the same MAP after the injury by 1 minute. So what are the results? So you can see here, and let me explain to you exactly what each one of them. So the black one, and this is the Kaplan-Meier, 100% that means all the animals are alive. And then divided into the three groups. So the control group, you can see immediately, and the lower is the time. So you can immediately see at 1 hour, which is 60 minutes, almost the survivability went down below 20% in the control group who only given IV fluids. While the green and blue, you can see at almost what? You are talking about 2 hours, 120 minutes. Still the survivable almost around 45% of the animals still alive. And even after 3 hours, you can see up to around 40% to 37% of both the preperitoneal group and the intra-abdominal group survived, while around 80 minutes, those who are only given IV fluids died. So we can say here that whether you give it intraperitoneal or preperitoneal, they both have the same efficacy. Another graph looking into the MAP, and you can tell here's the MAP versus the time. So in the MAP, once you cause the injury, there is a little bit, increase in the MAPs because as a refraction to losing this amount of blood, immediately there is a significant drop into the MAP all the way to around 20 to 25. Then they divide into three groups. The control, they continue to deteriorate. They respond a little bit with the fluid, then they unfortunately deteriorate to die around 100-minute time. While those with the preperitoneal foam and the intra-abdominal foam, they actually survived up to 3 hours. So we can tell that if you actually gave this material, you gave your patients around 40% of them, they will survive for 3 hours despite 100% mortality in these patients. This is just to look into the speed of bleed. So you can see that the speed of bleed, like the last line, which is the hemorrhage per gram per kilogram per minute, it's different in the control. They're around 4.5, while it's only half and versus 0.6 in the intra-abdominal. That's mean you give a material that slow the bleed, that's mean to prolong the survival of the patient. Makes sense? So in conclusion, again, whether you give it pre-peritoneal or intraperitoneal, they have the similar survival benefit, similar stabilization, and there is a reduction in the rate of the bleeding. So the problem with, and we conclude again that this can be given intra-abdominal or in the pre-peritoneal have a similar effect. The problem with the rescue foam, actually is very expensive material. So we end up talking with Arsenic into can we find a material that is very cheap and can be able to give the same exact kind of efficacy. So we use something called the chitosan-based life form improved survival and lethal closed abdominal. And actually in these patients, not only we just only cause a pelvic fracture, we actually cause a grade 5 liver injury, and we'll talk more in details about it. So this is just it's a DOD grant that we got. And the chitosan is basically a hydrophilic modified chitosan, which is a biocompatible. It's a polysaccharide plus a modified chitosan, and it's a 2-component that has not only caused the same expansion, actually has an hemostatic agent. And it's naturally abundant in the shells. Actually, it's a byproduct of the shells, so it's very cheap. And it's very low cost comparingly to the rescue foam. And again, this is what they say. You give the chitosan, it's actually react with the polymer, which is we use the gelatin, and you can cause this self-expanding foam. And the aim, we can say that we want to figure out exactly what is the optimal concentration between the two to find out the best, and we're going to go through the same things, the survivability, the best dose, and everything like that, but to a material that is less expensive, actually not less expensive, extensively less expensive compared to the rescue foam. And this is just the anatomy of the swine, which is the pigs, is different. They have 2 laterals and 2 medial lobes of the liver, and the portal vein is exactly at the middle between the 2 middle lobes. So we already did this. So the material I'm gonna explain to you, it has been done in previous pigs, and actually we proved that this is a lethal model, but even for the sake of the study, we end up doing 2 control, just to make sure that it's actually reproducible. But we did and tested 15 different concentration of this material. And we used the 3 to 4 months, again, swine, and we looked into, and we only included those patients that within the first 10 minutes, their MAP dropped to 30, less than 30, or there is a delta change around 30 millimeter mercury, and we end up doing a postmortem, and we actually looked at the IVC injury, and it has to be above 0.5 centimeter to make sure that this is a really lethal injury, and we included only those who have this injury during that. So this is the steps of the procedure. We made a neck incision. We placed the A-line in the carotid artery, and then we put for the central line, because we're going to give a lot of fluid, we put them in the external jugular vein. It's actually, the external is way more bigger and wider comparatively to the internal jugular in the swine. We put a bladder catheter, and we did an instrumental of the liver, and I'll talk more about it in the next slide. We externalized the wires, closed the fascia, and then we set up the novel for our injectable material. But this time is the material, the new one that the chitosan modified. And once the MAP become less than 60, we immediately give them fluid at a rate of 165 ml per minute. So this is how we end up doing. We actually externalize the wire. We're putting the wire all the way at the base of the portal vein, inferior vena cava, retrohepatic. And we use, in the beginning, when we use externalizing, the wire actually got cut. So we end up using the fishing wires, which is very strong, and that's how we end up figuring out that this is not gonna get cut. So we end up using a fishing wire, not only completely transect, we actually also suture both the medial lobe, the right and left, to keep the liver apart so they don't close the IVC and cause injury. We actually cause the injury, then we left the lobes of the liver open, so to make it, bleed more. And again, these are the study endpoint. We want to see how many of them survive, and how many of them died. This is at the end of the case how we can verify that the IVC, the portal vein IVC, portal vein injury is more than 0.5 centimeter. So this is a Kaplan-Meier again. Just in a summary, 100% of those who we gave the chitosan material survived, and 0% of those who did not get the foam, the chitosan died. And as I told you, this is a mortality, non-survivable experiment. So here in details, because we tried almost, as we told you guys, 15 different materials, you can see here. So the red line is exactly when the injury, when we end up injecting the material, because you see the 0 point is when the injury happened, and I will explain each one of you guys. So let's keep a look on the black one. So once we cause the injury, there is significant drop into the map, and once we start giving them only fluid, you can see that even within 25 minutes, 30 minutes, those patient only got fluid died, and those who have, this is the control arm, the mortality. Those who, they got the chitosan of this particular actually had a survivability to 3 hours, but there are flawed material that we end up giving and they did not survive, so we end up aborting those materials and label them as non-perfect concentration. So in conclusion, combining the optimal expansion with mechanical properties, and this is how we can tell that because the aim of the study is just to figure out what is the perfect sample, what is the perfect concentration. All of them survived to 3 hours, and there is a decrease in the blood loss. And hopefully this will, in the next steps of this procedure, we actually now, since we found what is the perfect concentration, we're gonna end up doing it looking into safety and the other steps the same way we went into the rescue form. And I forgot to tell you that in the rescue form, we're actually now in the phase of human implementation in the emergency room at Mass General. This is the paper that we were able to publish. This is the people that I did the research with them at Mass General. Thank you very much.
Thank you so much, Dr. Hassan. My name is Dr. Al-Marhabi, and now I'd like to introduce my colleague, Dr. Thamer Nouh. He's Associate Professor in King Saud University. He's also the founder of the first Trauma and Acute Care Surgery Clinical Unit in the university, and also the founder of the Trauma Fellowship Program in Saudi. Let's welcome him, and he will talk about the resuscitation in trauma.
Thank you, Yahya, and I would like to thank the organizing committee for inviting me and giving me the chance to present to you today. Let me see if this is going to work. I'm going to be talking today about resuscitation from bleeding in 2022, the what, how much, and when. And in the sake of time, I'll try to go a little bit quickly just to catch up. I'm going to start by giving you a brief about why is this important, why is resuscitation for bleeding an important thing. I'll go over a very quick overview about damage control resuscitation, the mass transfusion protocol, and important adjuncts. And then I'll spend some time discussing about whole blood transfusion and future pathways or future points that can help us in resuscitating from trauma. So as you can know, massive hemorrhage, as you probably know, massive hemorrhage is a very important topic in critical care. It deserves its own chapter or its own approach to dealing with a patient who is massively bleeding, as opposed to a simple bleeder that you give 1 or 2 units of blood and then they recover from it. Massive bleeding leads to coagulopathy, leads to hypothermia, leads to acidosis, and this becomes a lethal triad that is really difficult to get the patient out of it. Some patients actually are coagulopathic initially, even just because of the trauma. You develop coagulopathy of trauma even before you start getting into the lethal triad or the pathological problem that comes with massive bleeding. So like I said, patients who bleed significantly, they get into some sort of acidosis, coagulopathy, hypothermia, and this leads to a vicious circle that unless you can break the patient out of this vicious circle, it's very difficult to recover them or bring them back. And in addition to that, sometimes the actual resuscitation attempts that we do to the patient, that we give the patient, might lead to a further deterioration of their clinical condition. And we need to be very cognizant about what we're trying to do with the patient, because sometimes it leads to actual harm. So the initial approach that we use with patients to try to resuscitate them is to give them component therapy. And sometimes the component therapy itself, the blood that we give is old, so its ability to carry oxygen is not the best. The blood units are initially acidotic, so when you give the blood, you might exacerbate the actual acidosis that the patient is already in because of their shock. The platelets that we are transfusing, they're not normal platelets. They have a reduced functionality because they're stored. And a lot of the coagulation factors that we're giving to the patients, they're not really functioning at the best of their ability. So sometimes if we don't take this into consideration when we're giving the blood, we might also contribute to the worsening of the patient's situation. Because of this, we started looking into what we're calling damage control resuscitation. We need to take into account the way we resuscitate the patient. It's not enough to just give a couple of units of blood or a couple of units of plasma and we think that that's going to reverse it. There's an actual approach that needs to be taken into account while we are resuscitating, and there's an extensive amount of literature that is already out there discussing how to do damage control resuscitation. The two important parts is that we don't need to resuscitate the patient back to their normal pressure. So normally you need to accept some sort of normal or some acceptable form of hypotension or at least until you get control of the massive bleeding. So normally you target a blood pressure of about 90 to 100 systolic. And you should restore the intravascular volume with blood. The patient is losing blood, so you need to give them back blood, not packed red blood cells. You need to give them some sort of combination component therapy that resembles actual blood. And traditionally, there's been a lot of literature, whether this becomes 1:1:1 or 1:1:2. There is literature around this to discuss what we're giving the patient. This is the landmark trial that started our approach of looking into 1:1:1 component therapy, and basically shows very clearly that patients who are resuscitated, I don't know if I have, so patients that are resuscitated with low ratio, so 1:8, the mortality rate was about 65%. Patients that were considered a medium ratio, so about 1 to 2.5, mortality rate was 34%, and the high ratio, the mortality rate was 19%. And there's a lot of debate in the literature whether this is a survival bias, selection bias, but there's been enough literature coming out, and this is being done again and again to show that this is an actual signal, and this is something that we should try to approach. This is the proper randomized trial, and basically, let me see if I can go back. It shows that with the intervention that there's actually a decrease in death due to hemorrhage, where with the intervention the mortality rate is 9.2% compared to 14% in the control. So basically right now, because of all of this, it is not really acceptable anymore to do the massive transfusion or to treat massively bleeding or massively hemorrhaging patients according to your own approach. This is there's enough literature that shows that in 2022 you should have a massive transfusion protocol, and that patients where the blood bank becomes a partner and not just a reservoir for your blood component, becomes an actual partner where they make sure that they deliver the blood according in a rapid form. And studies very clearly show that patients who are treated using a massive transfusion protocol, that the odds of mortality is less. and that when you have an actual massive transfusion protocol, the time spent between request for blood and the delivery of the first cooler and the delivery of subsequent coolers gets shortened with a massive transfusion protocol. There's also literature showing that compliance with the use of with the use and implementation of a massive transfusion protocol actually leads to better outcome. Adjuncts. So normally it's not just component therapy that we use. We use blood, platelets, plasma, but there are actually component therapies that need to be also incorporated in your massive transfusion protocol or in your management of a massively bleeding patient. For example, tranexamic acid given within the first 3 hours of injury, it's associated with improved outcomes. Calcium is another component that needs to be thought of. When we give component therapy, there is citrate that leads to a reduction in calcium, and calcium is important for your coagulation profile, so that needs to be kept in mind. And there is a very important role for prothrombin complex concentrates in managing patients who are massively bleeding. Traditionally, we think of these as a way to reverse anticoagulants, but there's more and more literature today showing that giving actual the concentrates is better than giving plasma, and that there is push to replace plasma in your component therapy with concentrates as opposed to just giving FFPs. So this was a very quick overview of what we should do, and this should be already established standards of care that we should be using in our hospitals in managing patients who are massively bleeding. I would like to concentrate now, moving forward, about whole blood. And basically what I would consider is something that we used to use. It was standard of care at a point in time, and now we should be probably moving back towards back to the future and figuring out if we should use whole blood as opposed to using component therapy. In World War I, this is a paper that was published in 1918, and basically the conclusion back then was administration of saline worsens the acidosis and is harmful to the critically wounded. And back then, there was not, component therapy was not a thing, and the only way that they used to give patients blood on the battlefield was to actually give them whole blood. And so our experience with transfusion started with whole blood all the way back in World War I. But whole blood was hard, and moving forward from the First World War to the Second World War, we started trying to become very clever, and we started saying we need an easier way of delivering blood to the injured at the battlefield. And the whole concept of frozen dried plasma was initiated. And we started looking into how we can transfuse the injured in the battlefield and give them frozen dried plasma as opposed to whole blood, because whole blood was difficult. And the quality of frozen dried plasma is that it was a stable product. It was also, you can industrially produce it, so you produce a lot of it, very easily stored and very easily delivered to the front lines. And so people started using it in World War I, in World War II. But the results of using it, it was very clearly apparent, even back then, that when you resuscitate the patients with fluids and plasma was not sufficient, and patients did not do well, or the injured did not do well, and it was very clear that they needed to go back to whole blood. The problem with this approach is that they were not able to basically do what we're doing now to get the blood, prepare it, store it, and deliver it in a usable manner. So the whole concept of the walking donor or the walking blood bank was initiated then. It was too difficult to deliver on it in World War II, but it was very clear, especially in the US military's mind, that this was the right way forward, is that you need to the patients are losing or the victims are losing blood, you need to give them blood. And so basically whole blood, which is low titered type O blood, was used in World War I, World War II, and the results were very good. The actual transfusion reactions were very minimal, especially if you made sure that it was low titer low titered O negative whole blood. In Korea, there was about 400, in the Korean War, there was 400,000 low titer group O whole blood transfusions that were given, and there was no severe hemolytic reactions at all. And in Vietnam, only one severe hemolytic reaction happened as a result of transfusing 230,000 units. And when they looked at it, it was, the titer was more than the 250 target titer, so it was clear that if you abide by the target recommendation of having the titer low, you would not expect having any hemolytic reactions from giving O negative whole blood. So when did we get into this concept of giving crystalloids? Again, we tried to forget what we've learned, and we tried to make our life easy, and we started basically replacing giving whole blood, because it was difficult, with resuscitating patients with crystalloids, trying to basically depend less on whole blood. And this happened at the end of the Vietnam War. And I tried to look at the literature, figuring out where did this come from, and I could find the paper in the middle. This is probably the best basic science research that I could find, trying to emphasize that. And basically, they had an animal model, a dog animal model, where they shed blood, or basically tried to bleed the animal for 40% of their blood volume, and then replaced the blood back to the animal, and compared those that only got the blood versus those that got the blood with 5% lactated ringer. And they showed that this was safe, and that the animals returned back to the normal pressure in well, I wouldn't say a significant shortened time, but in a shorter time. I could not find any statistical analysis on that paper, but basically after these types of papers, we started looking at resuscitating patients with crystalloids, waiting for the component therapy to come. And so, as you can see, the evidence that we had for crystalloid therapy was not that great, especially in massively bleeding patients. This is a paper, although it's unpublished data, but it is basically comparing whole blood compared to all other crystalloids or blood substitutes, and it shows that the survival rate was best with giving whole blood compared to all of the other substitutes. This is in an animal model with an aortotomy leading to 50% hemorrhage. And resuscitation to an 80 millimeter mercury, and it shows that resuscitation with whole blood is better than resuscitation with anything else. Again, we go back to the, as the experience from the military became better, the wars in Iraq and Afghanistan showed us that resuscitating a patient or an injured victim with almost whole blood, so component therapy 1:1:1, almost trying to reconstitute whole blood, was associated with a better outcome compared to component therapy. And if this is done in a quicker time, it's better than if it's done in a less or a more relaxed time. So if you give the component therapy quickly, you get better results. And what's quicker than giving whole blood as opposed to giving the packed red blood cells, then the platelets, then the FFPs? And so basically we are trying to rediscover what we've already learned in World War I and World War II, is that giving whole blood is safe and better for our patients than giving component therapy. These are papers from the military showing that victims of war that received whole blood on the scene did significantly better than those that were given component therapy. And this was also, so some would argue this is warm whole blood. Normally, we don't have access to this in the civilian sector. So these are two papers that looked into how cold stored whole blood or the results of using it, and it shows the same, that if it's at least significantly associated with better outcome when used, and it is associated with less use of component therapy when we use whole blood. And this has also been replicated in the civilian sector. So there are certain centers in North America right now that are using whole blood and resuscitating massively bleeding patients. And the results were showing, again, significantly better or less mortality and less utilization of blood component therapy compared to when using component therapy. Some would argue, well, when we give 1:1:1, this reconstitutes the same as whole blood, and this is also looked at, and it's not actually the same. When you give 1 unit of whole blood, it's about 500 mLs. The hematocrit is anywhere between 38 to 50%. Platelets are anywhere between 150,000 to 400,000, and the plasma coagulation factors are 100%. But the balanced component therapy, first of all, the amount is more, so it's about 660 ml. The hematocrit is, although it's 55, but the platelets are less, and the plasma is, the activity of the coagulation factors are less. So trying to use 1:1:1 component therapy is not necessarily the same as using whole blood. And the other point is the actual anticoagulants and additives that are there in the component therapy. So 1:1:1 component therapy has almost about 1 liter of additives and anticoagulants associated with that, compared to about 378 mLs of additives in the whole blood. So there's clearly a 1:1:1 approach is not the same as a whole blood unit. And again, I'm trying to restate the obvious. It's not, when you give whole blood, it's not the same as component therapy. Component therapy is stored as 3 different components, stored in 3 different temperatures, takes time to reconstitute, as opposed to whole blood when you just give everything that the patient needs to the patient together. There's now AABB standards for storing whole blood. Hopefully this will come to Saudi Arabia soon. But basically, it permits using low titer O negative or O positive whole blood, leaves the setting for the titer control and the methods to the center itself. And you can also actually use, instead of using O negative, you can also expand this to use type-specific whole blood if that's something that you would like to do. The last point that I would like to say, so everything that I presented to you right now is old news, old medicine. We've known this 100 years ago. We're relearning it again now. Hopefully soon it's going to be standard of care. But is there anything coming in the future that would help us basically manage our patients better? These are the Nobel winners for physiology and medicine for 2019. They presented a way to try to help cells to adapt to hypoxia. This is still bench work, but there is evidence that at least in the bench, on the bench, in the basic science, it works. And basically, the administration of this compound would allow the cells to tolerate hypoxia better. Basically, this animal model shows that if you have a lethal hemorrhagic shock model and you give the animals this compound, it basically leads to an improved survival. It leads to an improvement, a higher arterial blood pressure, and it leads to a less production of lactate. So hopefully a better perfusion to the animal model. So I think in the future, we went from 60 years of utilizing whole blood in the battlefield to 30 years of trying to give clear fluids and component therapy. And now we're trying to go back to the future and maybe use whole blood again. And hopefully in the future, instead of trying to resuscitate our trauma victims who are massively bleeding with component therapy, we start using a combination of whole blood and maybe shock modifying drugs that would allow the patient or the cells to tolerate hypoxia better while we are trying to stop the bleeding. Thank you very much for giving me the chance, and if you have any questions, I'm here to answer.
The next topic, predisposed to fail, and challenge of the surgical rescue in ICU. My pleasure to introduce next speaker, Dr. Ahmed Al-Braikan. He is assistant professor, consultant of trauma and acute care surgery, and intensivist at King Saud University in Riyadh. He is also the chairman or the head of the chapter of the surgical critical care. Welcome, Dr. Ahmed. Okay, for your presentation.
Thank you, Dr. Adnan. It's a pleasure to be presented by one of the founding fathers of trauma surgery in our country. And it's also a pleasure to be talking in front of the audience. So I chose this topic because I think it's a cross-section between surgery in form of acute surgery and trauma surgery and in critical care medicine. Let's see if this works. Yeah, so we're going to talk a bit about what does it mean to say surgical rescue, and what does it mean to say failure of rescue of patients in our units. And hopefully we can talk about our role as intensive care and as acute care surgeons and how to optimize surgical rescue in our population and challenges in our country in particular. So what is surgical rescue? So, you know, we have seen those patients, and you guys, especially as intensive care specialists, have seen patients who develop a complication, whether they are surgical patients or non-surgical patients, but then they require some form of intervention or surgery to rescue them from this complication and bring them back to their usual state. So this is what we mean by surgical rescue, is to promptly intervene and salvage patients who have surgical, whether operative or other intervention complication. And when we say failure of rescue, that means the hospital death after adverse occurrences. So what is the burden of this problem? So we know in the United States that we have more than 36 million in hospital admissions, and of those, if you say 900,000 discharges were related to a complication of medical or surgical care. So that's more common discharge diagnosis than bowel obstruction, appendicitis, or even cholelithiasis combined. So it is a real problem. And in the surgical population, about 40% of the patients, they will develop in-hospital complications, whereas, again, in the medical ICUs, which is a common thing in the States where they have purely medical patients, you still have about 4% of patients who will develop surgical complications, and they will need to be in rescue from this complication by terms of dealing with their intra-abdominal pathology. This is some of the catastrophes that you guys, I'm sure, have seen many in your ICUs where the patient will need to be rescued from, and that goes from ulcerations to massive bleeding to abdominal mesenteric ischemia to cholecystitis to pancreatitis and others. But these are, the usual culprits that we see in our units. So, the burden. So we have found in the literature that there are, sort of a Pareto principle where about 20 to 30% of the patients are usually the troublemaker patients, the patients that will develop the complications, and those are the patients that will need to be rescued. And in the patients who develop complications, the mortality rises tremendously. So these are, fresh areas or fresh group of population where you need to really be ready to identify and deal with in order to improve the survival. And that also happens in patients who are non-surgical. And as you can see in this article, just by the fact, even in the medical ICU, if the patient develops a complication for which they will need surgical rescue, then the chances of mortality is even higher. So these patients are real patients that they need specific attention so that we can hopefully reduce mortality and complications further on those patients. So people have looked in also why some hospitals deal with these patients better than other hospitals. And this is an interesting study where they have shown that the difference between high-level or high-volume center than low-volume center is not in the amount of occurrence of complications, but rather by rescuing the patients when they develop complications. This is done in multiple US centers where high-volume are usually high-volume centers because of their reputation, because of their attention to detail, and because of the quality they provide. And they have found that complications will occur, and we know this. As surgeons and as intensivists, you will face complications. It's a good strategy to try to minimize complications, but also where a hospital can shine is where they usually can rescue the patient after an occurrence of complication. And as you can see here, there was no significant difference in the incidence of major complications between the very low volume hospitals and the high volume hospitals. But you see the huge difference in the mortality and the difference in the success of surgical rescue that happens in the high volume centers. So people wanted to look into why do hospitals perform better than other hospitals in terms of rescue of their patients. And as you can see, there are some risk factors that usually when happens and when the patients develop those risk factors, the mortality tremendously increase. And you can see here the failure rescue rate in the very low volume centers are much higher, specifically with surgical complications, but also with some of the medical complications. So certainly they do something better than the rest. So people have looked into what are the determinants that help the patients or help the hospitals to identify in those patients so that we can able to do to rescue the patients from complications. And here in this study by Colliff and Allen, they found out that, of course, if the patient is sick, higher scores of Apache, that will affect your surgical rescue success rates, but also the delays in diagnosis is also much more prevalent in patients who we fail to rescue. So here is something that we can work on and we can improve in order to reduce the diagnostic delay of these patients, find out that they've had complications faster, be able to relay these complications, and also be able to intervene as a multidisciplinary team and rescue those patients from complications. This is another study also where they looked at the factor that increases mortality in acute abdomen in the medical intensive care, and they also found out the same. If there is delay in surgical consultations, delay in surgical management, the patient's survival will decrease. So this is also a systematic review that looked into sort of cognitive factors, whether in patients or in the hospital staffing, and they found out that if there is delay in communication between the surgeon, between the intensive care, between the escalation of care, that also results in higher mortality. So these are all areas where you can improve in order to increase the chances of your surgical rescue of your patients. So in our King Saud University Medical City, we have established a database that takes care of our trauma and acute care admissions. And it was interesting to look at this data. We see all run-of-the-mills of acute care surgery, including trauma and multiple emergency joint surgery patients. And our data are sort of aligned with international benchmark, maybe slightly better actually we do in terms of mortality, maybe because our patients are not as sick in the population. But still, as you can see here, if there is we still have our share of complications, which is about 18% of the admissions. And this is, within the international benchmark. But it's interesting to note that even in our data, when our patients developed complications, the chances of mortality went very high. In patients who don't develop complications, the chance of mortality is very minimal, and the median hospital stay is acceptable, and the ICU admission post-operative is much less than in the patients where complications happen. So we need to be able to detect these complications and hopefully manage them in a better way. Okay, so what are the root causes of failure to rescue in the hospital? So this is a very nice systematic review that was done to sort of address why do we fail to rescue some of our deteriorating patients. And it's interesting, they come up with this paradigm that sort of summarizes the issue into three factors. So there is an issue in recognizing deterioration of patients, which I'm sure we have enjoyed many of the talks before us here, saying how we can sort of improve our recognition of patients who are becoming sick or who are developing complications. And then there might be issues in relaying the information, i.e. informing the surgeon coming to assess the patient, and relaying the information of sick patients to one another, and then the reaction also of the organization or of the surgeon to the patient who develops a complication. And they come up with some suggested intervention. And if you guys have been here since the beginning, we have discussed this already in many talks before me, where to have minimum staff and physician training, to have early warning scores, have also electronic warning scores where patients who are deteriorating can be picked up by these new modalities of detection and relayed to the appropriate specialties. But we also have to relay this information effectively, and also we have to react to this information effectively. If the patient develops a complication that's usually not surgical, then most of the hospitals still do a good job. We have RRT teams or RRS teams, if you want to call them now. We kind of pick the patients up early, admit to the ICU, but then if it turns out to be a surgical complication, there might still be a delay in informing surgery, with the surgeon coming in and evaluating the patient and then determining if the patient needs an urgent intervention. Okay, so here is the role of the acute care surgery, because even picking up these information, picking up the fact that the patient is developing a surgical complication is the first step of trying to improve your failure to rescue rate. But you need a dedicated surgery service, or a surgeon who is really willing and free to come and assist the patient and taking this high-risk patient and performing high-risk procedures so that you can improve the survival of such patients. And here is where the role of acute care surgery comes in hand. So last year, if you guys were there, we presented a talk about how acute care surgery services is becoming a necessity in our kingdom, and where acute care surgery should be consultant-led, have dedicated staff, so that this service can be responsible for emergency general surgery or emergency surgical intervention 24/7. That it should be separate than the elective practice. The surgeon should be really free to assess emergency patients, because time is of the essence, and they should have timely access to resources, including operation theaters. And we have presented back then how development of acute care surgery service usually is associated with improvements in timelessness of care, in improving outcomes, and improving resource utilization, and also in improving staff well-being. So just by having this, the virtue of being an acute care surgeon, being present for emergencies, being present for trauma activation and for emergencies, the surgical rescue has also seen its benefit from being taken care of by an acute care surgeon. And we see here a nice article that was presented in East in 2016 adding sort of the surgical rescue to the armamentarium of acute care surgery, whereas it becomes a fifth pillar, because they looked into a very busy acute care surgery services in the United States, and they found that there 13% of the patients that were managed by those services was for a surgical complications, and 15% were also because of endoscopic or interventional procedures other than surgeries. So it constitutes, you know, an important part of the acute care surgery practice. And here, the acute care surgeon is responsible for trauma, for emergency general surgery. They have usually an elective practice also to maintain skills, and now surgical rescue is rapidly becoming also part of the acute care surgery responsibilities. So how does the acute care surgeon participate in improving surgical rescue? Well, the acute care surgery service is a dedicated team. It's led by a consultant surgeon. They are responsible for emergency general surgery and trauma activation 24/7, to utilize technology and implement alert systems sort of to detect those patients who are teams with protocolized management, and we need to also have acute care surgery dedicated teams. So the take-home message is the problem of surgical rescue is real in our ICUs. Along with working on reducing the number of complications, we should also work on rescuing the patients who develop those complications, and the role of ICU and acute care surgery is crucial in these efforts. And with that, I thank you very much.
Okay. Thank you very much, Dr. Ahmed, okay, for your nice presentation. And I would like to ask the speakers, okay, to come to here. Okay, if there is any couple of questions, okay, to our speakers. No questions? Okay. Thank you very much. No more questions. Anyone? Huh? Thank you. Dr. Yahya?
And innovation as well. My question to Dr. Hassan Mashbari. How do you find this kind of innovation in the future of taking care of the patient, of trauma patient in Saudi Arabia? And also about the approval of the innovation, and at which setting you think we can provide this innovation to our patient?
All right, thank you for the question. So, so number one, this is already an FDA approved for even humans. So now we're actually using it at the Mass General Hospital ER, and we just actually came together from a meeting with the same people, Dr. David King, trying to figure out exactly how we can incorporate that and make it here. And the only thing I actually see it as a setting is that, for example, whatever is going on now with the war, for example. So the frontliners is that they don't have any trauma surgeons or an actual surgeons. The idea is that can you train a particular physicians or particular EMS to be able at the very, very, very front line of the war to be able to at least introduce this material to buy time for this patient to be transported in whatever the military vehicles to the triaging, then to a hospital. So that's where I see in where we can use this. I think in the hospitals, we just need to work on getting a good ER to OR and transfer time, and actually good resuscitation in the ER. Did I answer your question? Yes.
Yeah, thank you very much. I'm curious about the technique of peritoneal injection of foam to stop the bleeding. Intraperitoneal, okay, we know it. It can encase the liver or the spleen or so. But pre-peritoneal, how it go anatomically into the site of bleeding?
Yeah, so the pre-peritoneal, so in the pre-peritoneal is only going to take care of the pre-peritoneal bleed, which is the pelvic fractures. Okay, so it's only that's the time.
Yeah.
But
Yeah.
it's not going to take care of anything related into the intra-abdominal portion.
I mean, how it reached to the site, where you inject it.
Yeah, so you mean how they do it? So it's the same thing as you would do a pre-peritoneal packing, is that you make your incision in the infraumbilical, you go down just to below the, the anterior fascia without penetrating the pre-peritoneal, without penetrating the peritoneum, and actually just do a dissection and inject it in that space. And actually already the foam is going to expand really well to the point that it's actually going to cause the expansion of the dissection itself. So the beauty of this, it's that it can control both. So people are really used of doing the Hassan technique and the opening, so it's easier to do it that way, but just making an incision and just do it because people are used of doing DPL. It's hard a little bit in the doing in the pre-peritoneal if you don't have an experience with that. So having one method can take care of whether you have a pelvic or intra-abdominal, because most of the time in the whatever you are in the field, you cannot tell where is the bleeding coming from. So you just do it in the intra-abdominal, take care of two cavities at the same time, just to get the patient to the hospital. Did I answer your question? Oh, okay.
طيب, thank you very much. We will end the session and we will have 10 minutes break. Exactly, 4:05 we will start the session. We're sorry the program is half an hour late, so we'll start, but we would like to have our speaker for a second just to take a picture with them, with their gift as an appreciation. Dr. Adnan. You're a surgeon, you should take two.
السلام عليكم. مساء الخير جميعا. Good evening everyone. It gives me great pleasure to introduce the next coming session, and starting by introducing my colleagues, moderators. First one is Dr. Ali Sharif. Dr. Ali is a senior consultant of critical care and emergency medicine at King Abdulaziz Medical City National Guard in Jeddah. He is also a former dean of the College of Medical Applied Sciences and a former chairman of the emergency department at King Abdulaziz Medical City in Jeddah. My other colleague is Dr. Asia Al-Urgan. Dr. Asia Al-Urgan is a consultant intensivist at King Abdullah Medical City in Mecca. Also, she's the executive of critical care at Mecca cluster. After that, it gives me great pleasure also to introduce our first speaker, Professor Antonelli Massimo. Prof. Antonelli is a professor of anesthesiology and intensive care medicine and the chairman of the Department of Anesthesiology, Intensive Care and Emergency Medicine at Policlinico University Rome in Italy. He's also the former president of Society of European Intensive Care Medicine. So please welcome Prof. Massimo. He's going to speak to us today about non-invasive ventilation and high flow oxygenation and acute hypoxemic respiratory failure. So,
thank you very much for the introduction. Let me express the senses, still once again, the senses of my gratitude for the invitation. I'm sorry, I don't see this is my conflict of interests. I have no signal on the screen, but never mind. If we look at the possibilities or allocation of various modalities for treating patients with ARDS, we can easily see that for what concerns the high flow oxygen therapy and non-invasive ventilation, we are referring to the less severe patients in terms of PF. But as a matter of fact, anybody of you who have treated a COVID-19 patient knows that these devices, these possibilities are exploited for the COVID-19 patient, also for more severe patients, as a matter of fact. Interestingly, in this narrative review, are summarized the prerogative of the high flow oxygen therapy, and fundamentally there is an increased comfort, a reduction of respiratory rate of discomfort, a reduction of the work of breathing, and a small increase of the end expiratory lung volume. In the same review, there is an interesting suggestion that you may take into account just treating these patients with a high flow oxygen therapy. Has been coined a new score, a ratio of pulse oximetry over FeO2 to respiratory rate, just delineating different thresholds in various moments of the treatment and allowing possibilities of going on or moving toward other alternatives such as the endotracheal intubation. Is quite useful. However, the conference report and the expert panel, when has been asked to address the allocation of the resources concerning the hypoxemic respiratory failure, produced a strong recommendation. It's something that can be used at least as first-line intervention. The progenitor of the studies, randomized trials on the use of high-flow nasal cannula in hypoxemic respiratory failure comes from the REVA network in France. First author is Pierre Fratt, and in this study, he was capable to show that referring to the cumulative incidence of intubation, the device that performed better was indeed high-flow oxygen therapy in comparison to non-invasive ventilation or the standard oxygen. And indeed, this was even more true when we refer to PF below 200, more severe patient. Patients enrolled in this trial were indeed quite severe, almost all with bilateral pulmonary infiltrate, so, excuse me, and with PF which was below 160. Very recently, few days ago, the same author has published, focused on COVID-19 patient, a randomized trial into the JAMA, comparing the high-flow nasal cannula versus the standard oxygen therapy and addressing the mortality in patients with COVID-19 hypoxemic failure. Most of the patients had a PF below 150, and something like 350 patients were allocated in high-flow oxygen group, and the other to the standard oxygen. And the final results is negative. There was no difference in the mortality rate at 28 days. And interestingly, as it will be shown in another study that I'm going to show you in the next minutes, whilst there was no difference in terms of mortality, there was an advantage by delivering the high-flow nasal cannula respect to the standard oxygen in terms of intubation. Well, we have a line then. This is a real threshold. We'll see. If you look at the consensus conference with the ATS and ERS, indeed, there was an interesting suggestion. There was no recommendation for the use of non-invasive ventilation regarding this hypoxemic patient. But looking at the justification of this recommendation, there are interesting tools to look at. In general, it's recommended a trial of non-invasive ventilation, but when? When you have an experienced team, because these are serious patients. And the other very important point, that the patient needs to be carefully selected, reassessing when you approach with this procedure promptly when they are not improving. Referring to the non-invasive ventilation, I think that it is well known since the end of the last century, I would say, that it works and it ameliorates the gas exchange in a very similar way to what happens in invasive ventilation, and can also achieve a spare of serious complications such as the infections related to the presence of the endotracheal tube or sepsis, and also has the capability of reducing the work of breathing, here expressed in terms of pressure time product, when there is a combination of PEEP and pressure support, what we do. However, once again, looking in this context to the benefit or the risks, several studies, including this one coming from a French group, depicted that as soon as NIV fails, the possibility that patients gonna die is higher. So you need to be very careful. And this is also true for other categories of patients, include those who are immunocompromised. But certainly, if you postpone a needing intubation over a certain limit, the risk of being harmful and increasing the death is higher. However, there are always lights and shadows. You know the LungSafe study, the big epidemiological study conducted around the world, and where, if you look at the mortality rate for those patients who receive as first-line intervention the NIV, there was a reduced mortality in comparison to the invasive ventilation. However, as soon as you focused on those patients who were more severe, those having a PF below 150, the mortality rate was higher. So once again, lights and shadows. But why it may be so problematic? We know that the the transpulmonary pressure plays a major role in terms of inducing a potential damage. And under normal circumstances, you may have a situation like this, where the airway pressure is 20 and the pleural pressure is -5. As soon as a patient who's on spontaneous breathing starts to have deep inspiratory swing, may express pressures that are very negative inside the pleural space. And in this case, the transpulmonary pressure may be very high. This is a context and a situation where the damage can be induced. However, still, it's unclear when you reduce the work of breathing and then by using the pressure support reduce the inspiratory swing, if this is still harmful or not. The big problem, just looking at the situation, is that monitoring patients for their effort, placing in them always an NG tube that can measure the esophageal pressure as a surrogate, the pleural one, is not so practical at the bedside in all cases. So, probably, when we refer to the use of NIV in acute hypoxemic patients, we need a careful clinical judgment. We need to optimize the treatment. We need to mitigate the lung injury that we can produce. And you need also to detect the treatment failure, avoiding any potential delay in intubation. I guess that this study is a sort of seminal study because concerning these patients, all those with ARDS, not a big group, delineated a specific situation where the higher tidal volume expressed by these hypoxemic patients under non-invasive pressure support ventilation indeed predicted the failure rate. So if these patients start to have a deeper inspiratory swing and consequently producing a higher tidal volume, this may be at risk, as well as if we are referring to patients whose severity score is higher, and those patients whose PF doesn't improve after 1 hour of treatment. So you don't need to wait for days or many hours, but just at the very beginning of the treatment, you may have some indications on the possibility that the patients may be prone to die. Interestingly, this group showed how the assessment of heart rate, acidosis, consciousness, oxygenation, and respiratory rate may predict the failure of non-invasive ventilation, having a threshold above 5. And in this case, adopting this score may be very beneficial. This is the progenitor study of the helmet. It has been published at the beginning of the year 2000. It's an observational study and physiological one, where it could show that the helmet, respect to the mask, both on non-invasive ventilation pressure support, allowed a higher application of PEEP, and at the same time, a better tolerance for the patient. But the first study we were discussing together with Yasen Arabi today is the study coming from Patel and John Kress group, where was compared the use of the helmet with respect to the facial mask, non-invasive ventilation, in terms of the probability of the endotracheal intubation and the probability of survival. Believe me, this study was not titrated to demonstrate any difference in mortality, but significantly show a reduction on an intubation rate. And what was important in this study was that the difference was eminently in the PEEP level applied when the face mask was used in alternative to the helmet, and where the pressure of the PEEP pressure were certainly lower. Then, during the COVID period, we published a study where it was a pilot study where we compare the use of the high flow nasal oxygen and the non-invasive ventilation delivered through the helmet.
109 patients analyzed, 54 in helmet ventilation and 55 in high flow oxygen. And the study, once again, negative because there was the same median respiratory support 3 days in the two groups. However, as soon as we look at the secondary endpoints, and one of those was the cumulative incidence of intubation, those treated with high flow nasal cannula had a significantly less number of endotracheal intubation. This is just to show you how was our setting. And if you look at the number, in general, we adopted PEEP levels that were higher and a pressure support that can be also higher with respect to the facial mask, with some specific indicator that helped us to titrate on a single patient the use of non-invasive ventilation. But you have always to keep in mind that you may fail. Then, always, you have to refer to specific predefined criteria for the intubation. And as soon as one of those criteria is present, the message is always the same. Do not hesitate to intubate your patients. It's with pleasure that also I want to just allude to the beautiful study published by Yasen Arabi, once again on COVID-19 patients, and where the helmet non-invasive ventilation was compared to the usual respiratory support, once again in hypoxemic patients. 159 patients received the helmet non-invasive ventilation, and 161 the usually respiratory support that included also mask non-invasive ventilation in addition to the high flow oxygen or the standard oxygen. And the mortality rate, that was the primary endpoint, was not different. Interestingly, just in order to make a very brief comparison to our study, we may say that respect to the way in which we apply the helmet, this study was a little bit later than our data. And the other point that having 68%, almost 69% of patients in the control group, in the usual support group, receiving the mask ventilation, in large part the comparison is between the helmet non-invasive ventilation respect to the mask non-invasive ventilation. So these differences may explain some of the difference in terms of having a better rate of intubation, whilst in this study there was no real difference. Which are my conclusions? That non-invasive ventilation can be used for less severe patients. As a matter of fact, as I mentioned at the beginning, anybody of you knows how often these were applied during the COVID-19 and also severe patients, also because the constraint of resources. At times we hadn't any ICU beds, and we were obliged to treat also non-invasively outside the ICU. Continuous treatment, which is in general better tolerated with the helmet, and I share this view with Yasin this morning, may also help to have, for a longer period of time, a more adequate pressure support and PEEP. Certainly, the high flow oxygen therapy remains very useful, and up to now, and notwithstanding the results of the study that I showed you, there is no clear benefit in favor of one of the two techniques. In general, if you look at the possible indicator for a prompt decay of the respiratory conditions, the PF ratio, the higher tidal volume, the ACOR score, or when the patient is more severe or does have more organ failure, are all indicators in favor of a prompt application of invasive ventilation through the endotracheal tube. I sincerely thank you for your attention.
Thank you, Dr. Antonelli, for this informative and excellent presentation. Our next speaker is Dr. Neil Fredrickson. This is the third topic presented by him today. And for those who did not attend the morning session, I'll give brief about him. He's a head of critical care medicine at University of Health Network and Sinai Health. He's a full professor in the Division of Critical Care Medicine at University of Toronto. And he is a senior scientist in Toronto General Research Institute. Dr. Fredrickson researches or focuses on mechanical ventilator, ARDS, and ECMO. And he is the chair of Critical Care Canada Forum, which is the premier critical care conference in Canada. So please welcome Dr. Fredrickson. He is going to present diaphragm protective ventilation for us. Welcome, Dr. Neil.
Okay, good afternoon. Good morning from Toronto, and I'll just see if I can share my screen, which the host needs to enable. If somebody on the back end could enable screen sharing, that would be great. There we go. Okay, hopefully you can see my
Make it full
slides.
screen, please.
Can I get some confirmation that you can both hear me and see my slides?
Complete your presentation. You are live now.
Perfect. So we're going to talk in the next 15 minutes about diaphragm protective ventilation, a bit of a switch from earlier talks. I'm sorry I wasn't able to give those live, but it was very early in the morning here in Toronto. Thanks again to the organizers for inviting me. These are my disclosures, nothing particularly relevant for this talk. So this is an old paper from Const Manhouse and Jesse Hall and colleagues, which I still like actually as a framework for thinking about the difficult to wean patient, but as a systematic approach to that. One of the key messages though is that diaphragm weakness is an important cause of weaning failure. You can measure respiratory muscles and monitor them in a host of ways. This nice overview from Leo Hunks and colleagues in the Blue Journal for your reference. The gold standard for really measuring diaphragm function involves magnetic twitch stimulation of the phrenic nerve, as you can see here. This works pretty well in the respiratory physiology lab, but it's challenging in critically ill patients. Just even getting consent to do this, but also for technical reasons because of unmeasured changes in thoracic volume over time and potential lack of supramaximal stimulation. So we don't see it used very often, although there is one study from Alexandre Demoule and colleagues showing a significant degree of diaphragm dysfunction using this technique, which translated into significantly reduced survival. A quick anatomy review here. Remember that the diaphragm, we're used to sort of seeing it in the chest x-ray, but where we see the dome. But the major part of the diaphragm that does the work for us is in this zone of apposition against the rib cages, where it essentially works like a piston, drawing down the dome of the diaphragm to increase intrathoracic volume and create negative pressure in the chest. We can use ultrasound to measure diaphragm function. And historically, this has typically been used to look at the degree of diaphragm excursion, how much the diaphragm is moving down with each breath. That obviously accounts for both movement that's created by the patient or that's generated by the ventilator in a mechanically ventilated patient. More recently, we've been looking at measuring diaphragm thickness and changes in thickness over time as a measure of diaphragm function. And you can can see here in the using a linear probe in the zone of apposition, we have the two layers, the pleura and the diaphragm, in the middle here, with the liver providing contrast below. If you look at this over time in M mode, you can see over here that the diaphragm thickens with each muscle contraction the same way as your bicep thickens when you flex your arm. And we can measure this, we can use this to measure the resting thickness of the diaphragm here as a measurement of muscle bulk. And we can measure the thickening fraction, which is the amount that it changes with each contraction, as a measure of muscle activity. And we've done some work to show that this can be a reliable measurement, but you need to do it carefully. It's really only reliable when you do it on the right side, because without the liver providing contrast, it's quite tricky on the left side. And to have inter-observer or reliability over time, you really need to do it at the same spot. So we use the X mark spot technique when we're measuring this over multiple days. Now the diaphragm, as I hinted at earlier, can be injured by a whole number of factors. Dysfunction can be brought on by sepsis, shock, medications, critical illness, neuromyopathy. But in this talk, we're going to focus on another potential mechanism, which is the input of mechanical ventilation. Injury leads to contractile dysfunction and prolonged mechanical ventilation. So how does ventilation and the diaphragm interact? Well, when there's no ventilation happening, in this example of brain-dead organ donors, atrophy occurs extremely quickly. In just an average between 18 and 69 hours, profound myofibril atrophy here compared to controlled thoracic surgery patients who are only ventilated for 2 to 3 hours. And there's a stronger relationship between diaphragm dysfunction and weaning failure than ICU-acquired weakness. We sort of sometimes think general ICU-acquired weakness can be easier to see for us as clinicians at the bedside, but in this study from Marc Dress, and again the group of Alexandre Dumoule in France, a much stronger correlation between the presence of diaphragm dysfunction and difficult or prolonged weaning. Many patients who have general weakness were still able to wean quickly. Now, different forms of diaphragm dysfunction different patterns can be influencing diaphragm dysfunction here. And Ewan Gallagher and Laurent Bouchard and I sort of quantified them here in this Lancet paper a few years ago. You may have diaphragmatic quiescence, where the diaphragm is not contracting enough, and this leads to atrophy and myofibril damage. There's also possibly a mechanism of injury through excess muscle loading, and through patient ventilator dysynchrony, where we have eccentric muscle contractions, again leading to injury and dysfunction. And we made these observations in part after a series of daily measurements of diaphragm thickness and activity in mechanically ventilated patients. Patients fell out into 3 groups here. Group in red, there was a rapid reduction in the diaphragm thickness over just the course of just a few days. So we saw atrophy setting in by day 4 and 5. In about half the patients, no major change in their diaphragm thickness over time. And in a smaller but significant group of patients, we saw a significant increase in the diaphragm thickness over time. And this graph summarizes what influenced that. In this axis is the change in diaphragm thickness over time as you go forward in time, and considering how much activity the diaphragm is doing. So in patients who had a relatively normal amount of diaphragm activity with a thickening fraction of around 25 to 40%, there was not a lot of change in their diaphragm thickness. In patients who were doing very little with their diaphragm, rapid reduction in diaphragm thickness. And in patients who were exerting themselves a lot and having a lot of activity, this is where we saw that increase in diaphragm thickness. And this was related to the amount of driving pressure they were receiving from the mechanical ventilation, from the mechanical ventilator. So patients who lost the most diaphragm thickness were receiving the highest driving pressures on the ventilator. And then we were interested to see if we could develop these findings further by extending this cohort. And here's the bottom line from this larger study, which includes those first patients, that on any given day of mechanical ventilation, your chance of getting liberated from the ventilator was highest when your diaphragm thickness was closest to its baseline thickness value. So patients who had either a reduction or an increase in diaphragm thickness were less likely to be liberated from the ventilator. Looking at this another way, there's not a major difference in alive or death here, but in liberation from the ventilator among patients who are alive, the black line here is patients who had no change, less than 10% change in their diaphragm thickness, and the blue and red lines are either increase or decrease in diaphragm thickness. So a significant decrement in their ability to wean from mechanical ventilation. Looking at this another way, there's a bit of a U-shaped curve here in terms of so a nice dose response in terms of the shortest duration of mechanical ventilation happening with the less change and increasing on both sides. Or looking at complications of mechanical ventilation, death in hospital or reintubation, tracheostomy, or prolonged ventilation more than 2 weeks. Again, a U-shaped dose response curve related to change in diaphragm thickness. And this is similarly seen when we look at the amount of activity that the patient is doing over time, thickening fractions in the normal range having the shortest duration of mechanical ventilation. And so we think this rubric fits together like this. Patients have acute respiratory failure. They require mechanical ventilation, either controlled or partially assisted modes. Often they have either insufficient or excessive inspiratory efforts. And this as measured by diaphragm thickening fraction or electrical activity of the diaphragm. This leads to altered structure with increased or decreased diaphragm thickness, which is mediated by effort. And this leads to difficult liberation from mechanical ventilation, mediated by changes in thickness of the diaphragm, and through this causal pathway, presumably of impaired diaphragm function, although we didn't measure this in all patients. So I've tried to convince you so far that there's a growing evidence for the role of ventilation in iatrogenic diaphragm dysfunction. We like the term myotrauma as a term analogous to other forms of ventilator-associated iatrogenesis. And these are new data that link ventilator settings to diaphragm activity, to clinical outcomes. So the next question is, well, what about muscle protective ventilation strategies? We should prevent disuse, prevent excess loading, and prevent eccentric contractions, which is just what I've said here. Consider maintaining normal effort levels when possible and safe to do so in patients on mechanical ventilation. So that implies that we have to now measure the patient effort and do that quantitatively rather than just assessing the patient from the end of the bed. We can do that in a number of ways, and I'll briefly go through some of these now. An esophageal manometer can directly measure how much negative pressure is being generated in the chest. And these are increasingly easier to use, and many ventilators will accept an esophageal balloon input and allow you to calculate transpulmonary pressure and measure patients' efforts directly on the ventilator. You can also measure, in some ventilators, a plateau pressure during spontaneous breathing. And if the patient is relaxed, you may see the plateau pressure actually increase to the degree that the patient has made additional efforts. And this is reflective as the patient relaxes against a closed airway, their airway pressure rises to the same degree that it dropped when they lowered their diaphragm to take a spontaneous breath. You can measure the P.1, the pressure measured in the first 100 milliseconds of a breath. Most ventilators will do this, and Irene Kellyas has shown that that's accurate compared to bench efforts, and can be quite specific and sensitive for low efforts, and moderately so for high efforts when trying to normalize patients' respiratory demands. Another measure which we use pretty routinely in our ICU is an end expiratory occlusion pressure, or a stealth sort of negative inspiratory force maneuver. Just a expiratory hold without telling the patient that it's coming, and a negative occlusion pressure is generated. This allows us, based on data from correlations with esophageal pressures measured simultaneously, we can predict the amount of PMUS that the patient is using by multiplying by 0.7, and we can calculate or estimate the entire transpulmonary driving pressure by adding the positive pressure delivered by the ventilator and then adding the negative pressure generated by the patient by multiplying this occlusion pressure by about 0.6. One can also use proportional assist ventilation, which is continually measuring work of breathing through the equation of motion to measure effort. And all of these tools can be used to make sure that we're in the desired target of not too much, not too little patient efforts. When the patient is having over-assistance myotrauma, too much ventilatory support and not enough patient effort, you can reduce support when possible. Maybe think about diaphragmatic pacing as an experimental technique, and consider diaphragm training when injury has already occurred. Just to show you, there is work being done. As I said, you can pace the phrenic nerve through a intravascular catheter. This works in pigs and is just being evaluated in humans. And if patients have already developed weak inspiratory muscles, some inspiratory muscle training through loading may be helpful. When patients are having under-assistance myotrauma, i.e. they're doing too much work, here you can increase the amount of work that the ventilator is doing, but again, be careful with tidal volume, and there's a trade-off sometimes between ventilator-induced lung and ventilator-induced diaphragm injury. Increasing PEEP may recruit lung and reduce respiratory drive. You can neuromuscular blockade the patient. Obviously, you may be trading under for over-assistance. Partial neuromuscular blockade may be possible, and extracorporeal life support and extracorporeal CO2 removal may be slightly helpful here in avoiding this cycle of patient self-inflicted lung injury. So I'm just going to skip over these slides. Just a feasibility study from Leo Hunk's group showing that one can use low doses of rocuronium and achieve safe tidal volumes with acceptable patient efforts. I've tried to explain that how we set and use the ventilator impacts diaphragm function, which in turn impacts clinical outcomes. That measuring patient effort, therefore, is important. We should try to minimize asynchrony and avoid both disuse and excessive efforts. And with there, I will stop and be very happy to take any questions. Thank you very much.
Thank you, Prof. Ferguson, and Bismillah ar-Rahman ar-Rahim, Assalamu alaikum. It's really nice to see a good number of attendees toward the end of today's program. I would like to introduce our next speaker. Our next speaker is Dr. Saad al-Rabi'a. Dr. Saad al-Rabi'a is Vice Dean of College of Applied Medical Science at Prince Sultan Military College, Dhahran, and he's assistant professor and consultant in respiratory care, as well as the IRB chair of the same college. Dr. Rabi'a has more than 24 years of experience in healthcare sector as well as higher education. Please welcome Dr. Rabi'a. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm glad to be here with you today. It's my honor and privilege to talk today about an important subject that matched the theme of the last session, which is mechanical ventilation, more specifically weaning from mechanical ventilation. And as my previous colleagues talked about non-invasive ventilation, which is an avoidance of invasive ventilation, and Dr. Ferguson earlier talked about how to protect patients while they are on the mechanical ventilation and protect the diaphragm, which will lead to, inshallah, successful extubation. And I hope I can know how to use this. Let's try something. So our objectives for today is to list the weaning parameters, which I'm sure that all of us are aware of it. Compare the three standards of mode of weaning in relation to their success of discontinuation, define the closed loop mode, and actually the closed loop mode, our colleague, Dr. James Lewis, was talking about artificial intelligence and machine learning mechanisms and technology in order to gain data and gain information that will lead to, inshallah, that will lead to increase the accuracy and the validity of the decision making. But as mentioned earlier in that presentation by Dr. Jane Lewis, we have to make sure it's valid information before we rely on them. And we will talk about the recommendation from the recent recommendation from the American College of Chest Physicians and the Society of Critical Care Medicine and the American Association for Respiratory Care, which they have 9 major recommendations related to weaning. So initially, why did we intubate such a patient? The underlying cause and refractory correctable problem, we need to make sure of gas exchange, and all the list that you are saying, almost all of us are aware of it when we are planning to wean the patient or liberate the patient from mechanical ventilation and eventually disconnect him or her from mechanical ventilation. And there is an argument, there is a big difference between weaning, liberation, and discontinuing mechanical ventilation, because weaning is the process when you are doing it, and sometimes what we are doing is we are weaning the patient. Actually, we are not going toward discontinuation because we are exhausting the patient in the way of weaning that we are doing. And we will look at that soon. So after ensuring, we usually go gradually and drop the mandatory respiratory rate, reduction of pressure support, ensuring that the patient is spontaneously breathing, generating enough volumes that match his ideal body weight. We are making sure that the gas exchange is up to the limit and be equal to 5 or less than 8. This is the general figures or general numbers. However, again and again, it is the underlying problem or the under reason why did we intubate the patient. So generally, weaning parameters, it should be less than 25 breaths per minute, spontaneously generated, and we have to look at BaO2, FiO2 ratio to be less than 200, also the rapid shallow breathing index to be less than 105, and lung compliances. So again, there is modes that we are all comfortable with when we start weaning the patient. We either put him in a CIMV, then start gradually reduction, the tidal volume or the rate. Then we put him in pressure support or spontaneous breathing trials. And there is an argument about a CIMV that a CIMV sometimes may aid into asynchrony with the patient. And there was in the early introduction of a CIMV, the medical community believed it's a weaning mode. However, you need to assess your patients. And usually low CIMV or low CIMV rate may aid into asynchrony. And there is an ongoing argument about that. What is now available in most ventilator, and these names are intended just about the concept of the closed loop or the artificial intelligence of weaning within the ICU. So there are automated tube compensation that will compensate for the tube. It is a mode that is available, or a weaning mode that is available in some machines. Also volume targeted pressure support, which is another pressure support that guarantees the volume. And also auto mode and mandatory minute ventilation, adaptive pressure support, then the artificial intelligence system. The automatic tube compensation ensure that the resistance or the dynamic resistance that is created by the airway resistance that's created by the endotracheal tube and it's created for the dynamic lung compliance is reduced and monitored closely in order not to exhaust the patient or underventilate the patient. And as my colleague earlier mentioned, Dr. Ferguson, he mentioned when there are airway resistance, you need to make sure that you are not underventilating or under-assessing the patient in order to look for your vision earlier, which is discontinuation from mechanical ventilation. Volume targeted pressure support, it's the mode, which is the opposite of pressure support in terms of the mechanism. You are guaranteeing the tidal volume delivered to the patient, but it's generated by the patient himself. So the tidal volume that is going there is dependent on the change of the flow that is done by the machine to ensure delivery of a target tidal volume. And that tidal volume should be set on a spontaneous base, not a mechanical base, because spontaneously, usually 3 to 5 mils per kg is the spontaneous tidal volume that we know of. It's not 6 to 8. You are not targeting a mandatory or a mechanical breath. You are targeting the patient to be taking it spontaneously at its level to mimic the natural or physiological tidal volume. However, value in weaning has not been established, and this mode, the volume support ventilation, been there for a long, long time. I remember it was in one of the early ventilators that is being used in the early 2000 and 2001. Auto mode or variable pressure support ventilation, it varies the pressure to meet the patient demand, to synchronize with the patient, which is the key concept. We are trying to stay away from asynchrony because asynchrony will put more load on the patient and will add insult to the injury. And you may, the respiratory therapist, physicians or nurses, or healthcare provider, critical care provider, they may assume failure due to this single parameter. However, it is important to ensure that the asynchrony is not there. Mandatory minute ventilation, ensuring that the patient is receiving the minute ventilation that is set for him. Any drop on that will indicate that the patient is not really generating what is needed by him. Adaptive support ventilation, again, it's the same thing. I'm sure all of us are aware of it. It limits the breath that targets the volume and rate. It's selected by the ventilator algorithm, provides minimum work of breathing, and again, we are trying to synchronize with the mode. Artificial intelligence or closed loop system or automated machine learning, this is one of the important trending topics. It started, the latest paper published, I think, 2020, and it is communicating with the patient. And again, it's trying to learn from the patient what is his comfort in order to achieve successful weaning. And again, as mentioned by Professor Lewis, we need to make sure it's valid, and now we will look at the available literature about that. It is respiratory pressure is automatically to maintain the patient respiratory effort with the zone of comfort. Again, it's a closed loop within the patient. The lowest level of respiratory pressure is achieved. It monitor the period is initiated pressure. It's modified spontaneous breathing trial. So automated, it comparing automated weaning and spontaneous breathing trial. It compared to 10 small trials, and the quality of evidence ranges from low to moderate, may benefit patients who are difficult to wean. Sometimes we have patients who are straightforward, clear by the clinician to decide to wean them directly. They go and they apply the regular weaning. However, the more the patients stay, when we approach 21 days, we are heading toward tracheostomy. So during that time, it's good to use the data that these type of modes will provide us, to provide them to the decision makers in the ICU to aid in the decision making. Also, the efficacy and effectiveness of machine learning for weaning in mechanically ventilated patients at the intensive care unit. This is again a systemic review. It's from 9 studies. The available database development of machine learning in this clinical area may still be inadequate. And as you can see, this is in 2018. None of the review studies reported the procedure or the treatment or the whole sedation strategies and the whole picture about the patient. Machine learning may meet the needs of difficult to wean. Again, difficult to wean, they have concluded similar finding. Again, this is another study also to versus automated, non-automated weaning. Again, this is machine learning. May reduce weaning and ventilation duration and ICU stay due to the substantial trial heterogeneity and it's not adequately powered. So the available data again, or the available evidence is from low to moderate. So the main recommendation from the American College of Chest Physicians, American Association for Respiratory Care, Recommendation number one is the pathology of ventilation dependence, why the patient is staying on the primary event that causes, and why the patient is continuing on mechanical ventilation based on the respiratory care plan. So you make sure it's adequate oxygenation, adequate work of breathing. And also assessment of the readiness using evaluation criteria. Again, it's going back to the underlying cause, adequate oxygenation and ventilation, which is gas exchange basically. Patient capable of initiating respiratory effort, you are not exhausting him. And one of the major recommendations is again, assessment of breathing drought during substantial ventilatory support, removal of based on ability of the patient to protect his airway, patient receiving mechanical ventilation. All these recommendations are repetitive. However, one important factor is when the patient fails spontaneous breathing, try recommendation number 6. Usually we put him back, the spontaneous breathing, usually you put him back in the mode that he was on, which is not fully supported. So the recommendation is he should be put on non-fatigue, comfortable mode of ventilatory support in order to compensate for his failure, because maybe putting him, sometimes we see patients, we weaned him from rate of 15 to rate of 6, then put him in spontaneous breathing trial. When he fails spontaneous breathing trial, we put him back to 6. Actually, he needs to relax for a while before it's done that. This is one of the recommendations. And also the anesthesia and sedation strategies and ventilator management. An early extubation should be used as post-surgical for post-surgical patient. And the tracheostomy should be considered if we fail intubation, fail weaning and discontinuation from mechanical ventilation, and should be performed again when one more benefits ascribed procedure. So the take-home message from this, there are machine learning modes within the machine itself that we may learn from them. We may use them again to aid in the decision making. The technology available in the mechanical ventilation is evolving and improving and moving forward. One thing is we don't want to wean the patient to exhaustion and fatigue, then we go back to square one. We need to make sure that the settings, the whole critical care team are on the same page in terms of ventilation, oxygenation, or gas exchange, in terms of nutrition, in terms of resolving underlying or primary cause. And by that, inshallah, I conclude my presentation. Thank you for your time, and honored to be here with you.
Thank you very much for the interesting subject. We'll proceed to the next speaker. The topic is going to be about managing hospital-acquired pneumonia and ventilator-associated pneumonia in patients at risk for high mortality, and especially when it comes to the gram-negative resistant organisms. Our speaker is Dr. Basim Al-Raddadi, and he is Consultant Infectious Disease Chair of Research Unit, Department of Medicine at King Faisal Specialist Hospital and Research Center in Jeddah, and he is also an Associated Professor at Al Faisal University. Dr. Basim, the stage is yours, please. Thank you.
Thank you all, and it's a pleasure to be here, and thanks for the invitation from the Critical Care Society and from MSD for sponsoring this talk. So I'll just wait for the slides to load up. Okay, thank you. So, sorry for that. So what I will be discussing in the next 25 minutes, 30 minutes is I'll talk about some of the epidemiology of the gram-negative resistant organism, and then maybe quickly I'll discuss some of the selection of antibiotics that we usually use in patients with hospital-acquired pneumonia and ventilator-associated pneumonia. And then maybe I'll focus on the study for the using ceftazidime tazobactam for a patient with hospital-acquired pneumonia. So as you know, probably you've seen this report. This is a report published by the WHO in 2017, where they identified a group of organisms to have a priority, or designated to have a priority for research and development. And among these group of bacteria were the Acinetobacter baumannii, the carbapenem resistance, Pseudomonas aeruginosa carbapenem resistance, and Enterobacterales carbapenem resistance, including also the ASBL producer. So these are the highest priority bacteria for research and development from the World Health Organizations. CDC also, probably a couple of years later, they published a similar report where identify the carbapenem resistance Acinetobacter and carbapenem resistance Enterobacterales as an urgent threat, and where multi-drug resistant Pseudomonas were designated as a serious threat. And the reason for this is based on what available agents that we can use to treat these bacteria, and the outcome associated with these bacteria. So before I think it's maybe quickly to go over some definitions that we use in infectious diseases when we talk about the gram-negative bacteria. So we say that bacteria is MDR when the bacteria have non-susceptible to at least one antibiotic in 3 classes, and XDR where the bacteria is non-susceptible to at least one antibiotic in all classes except 2, and the band-drug resistance where bacteria have non-susceptible antibiotic from all the classes. And probably, especially maybe in the critical patients, you've seen types of these bacteria. And I think it's important to understand the mechanism, and this is very important for us when we treat patients with the serious gram-negative infections. This cartoon for the bacteria is showing the main classes or the main mechanism of resistance, and this is antibiotic inside these bacteria. So the problem with bacteria such as Pseudomonas, it can have more than one mechanism of resistance, and that's why you see the bacteria sometimes is resistance to all classes or resistance to multiple antibiotic classes. So I think here are some definitions, and probably you've seen this a lot when talking about hospital-acquired pneumonia, and the most recent IDSA guidelines changed the definitions of a hospital-acquired pneumonia, where you have a category of patients who admitted after 48 hours to the hospital and develop pneumonia. Those will be considered hospital-acquired pneumonia. And then you have the ventilator-associated pneumonia, where those patients who been on the ventilator more than 48 hours. And then you have this new category of patients of particular importance, and I'll mention why, which is the patient who had a hospital-acquired pneumonia and then required ventilation. And the reason why this category of patients is important, this patient actually have the highest mortality among the 3 classes. It's their risk of death is way higher than almost double compared to ventilator-associated pneumonia. And the other thing is the comorbidities, the seriousness of the infection of these patients is usually different from the others. Those patients usually tend to have a higher SOFA score and higher Apache score on presentation. And here is this is a prospective study looked at the all-cause mortality among the three. If you look at this bar graph, on the y-axis you see the percentage of mortality, and the x-axis you see the category of patient I just mentioned, so hospital-acquired pneumonia, and then the mortality is 21%, ventilator-associated pneumonia is 27%, and in the middle you see those patients hospital-acquired pneumonia who required ventilation. Those patients, almost 40% risk of death. And as I mentioned, those patients tend to have a higher SOFA score and higher Apache score when compared to the VAB patients. This is also a study that looked at the timely or the timing of antibiotics and the importance of starting the antibiotics as early as possible in this category of patients. In this decisional model framework study, where they look at the cost effectiveness of starting antibiotics on time, they evaluated patients who received the antibiotics less than 2 days, appropriate antibiotics, so antibiotics where the bacteria were susceptible to these antibiotics, or a patient who received inappropriate antibiotics or received the antibiotic more than 2 days, appropriate more than 2 days. And you can see here clearly that the mortality were very different between the two groups. Those patients who received appropriate antibiotic within 2 days, risk of death was 18% versus 43%. Also, I included also a meta-analysis and systematic review that looked at the cost effectiveness of multiple studies, and this meta-analysis showed that the patients who receive appropriate antibiotics have a less risk of death and much lower length of stay when compared to the patients who receive inappropriate antibiotics. What do we expect in a patient with hospital-acquired pneumonia, or here is the prevalence of gram-negative pathogens collected from respiratory tract infection in critically ill patients. Although this is from the SMART program, maybe this is not applicable to what we see in our ICUs, but as you know, our rate of gram-negative is way higher compared to the studies from other countries. So as you can see here, the most prevalent organism were Pseudomonas, Klebsiella pneumoniae, and E. coli. So these Enterobacterales and Pseudomonas represent more than 50% of all all bacteria causing respiratory tract infections in critically ill patients. So what is the rate of resistance in these bacteria? It's actually quite high. So you can see that for Pseudomonas, meropenem resistance, 31.6%. And I'm sure maybe in your hospital or in your facility in the ICU, if you look at all Pseudomonas, you will find the carbapenem resistance. Sometimes it's higher than this. At least in my hospital, in our ICU, the Pseudomonas resistance to carbapenem is around 50%. Similarly, Enterobacterales, but it's to much lesser extent. Its carbapenem resistance it's increasing. So I think very important when selecting antibiotics, maybe to focus on the cross-resistance or the cross-resistance between different beta-lactams. And that's why I presented the mechanism of resistance, especially for Pseudomonas and Enterobacterales, that they could have more than one type of resistance. This is an in vitro study, but done on in all critically ill patients in ICU where respiratory, non-urine samples, so respiratory and blood samples were collected, and they looked at the rate of cross-resistance. You can see here that the rate of cross-resistance between cefepime and meropenem was around 60%, and between Beptazo and meropenem was around 54%. However, when looking at antibiotics such as ceftolozane, tazobactam, the most of patients who were not susceptible to at least one beta-lactams were still susceptible to ceftolozane, tazobactam. And by the way, overall in this study, 97% of the bacteria in vitro were susceptible to ceftolozane, tazobactam. I'll mention why. I'll explain why ceftolozane, tazobactam has this specific susceptibility profile when compared to the other beta-lactams. So I'm sure most of you appreciate that when treating patients with ventilator-associated pneumonia or pneumonia in ICU, that you need to achieve a concentration in the epithelial lining fluid to cover the MIC for that particular bacteria. And this is, I think, this is a study that done specifically for ceftolozane, tazobactam to identify the concentration of the drugs that reach to the epithelial lining, and this concentration showed that it's actually higher or adequate for that bacterial MIC. Here is the ceftolozane, tazobactam, or Zerbaxa. Why the Zerbaxa, when we evaluated the cross-resistance, Zerbaxa were outperformed most of the beta-lactam, or the cross-resistance were not seen with the ceftolozane, tazobactam. If you look at the different type of mechanism of resistance, such as the porin loss, the beta-lactamase, the efflux pump, most of these ceftolozane, which is the component that it's active against Pseudomonas, still working well with these mechanism of resistance, where, for example, ceftazidime, cefepime, and beptazo, and carbapenem could not overcome these types of resistance. And what about the activity of ceftolozane, tazobactam for the other Enterobacterialis? Again, you can see that the other component, with the beta-lactamase, which is the tazobactam, is able to achieve or overcome at least the ESBL enzyme. However, it's not active for KPC or CRE in general. So ceftolozane, tazobactam is not recommended for a patient with carbapenem resistance Enterobacterialis. Of course, resistance is a concern. So this study is a little bit old, so maybe 3 to 4 years ago, we started to see resistance developing after exposure to the drug, and we are seeing some resistance to the Zerbaxa. So this is previously, this is not the main focus of the talk, but these are, as you know, the Zerbaxa were previously approved for the complicated UTI and complicated intra-abdominal infections at a dose of 1.5 gram every 8 hours, and received an FDA approval for that. I think also one important thing in the critically ill patients, the BKPD study, patients with the pneumonia in the ICU or ventilator-associated pneumonia usually exhibit unpredictable pharmacokinetics profile, and I think these types of study, to make sure that the concentration of the antibiotics in the target site is actually above the MIC, is quite important. So this is a study done to evaluate the ceftolozane, tazobactam in real patients and critically ill patients. And you can see here the minimum inhibitory concentration at 4 or minimum inhibitory concentration at 8 of the bacteria, which is the intermediate susceptibility. You can see that the epithelial lining fluid, you can see that the concentration of the antibiotics was above the MIC. So this is the main studies I wanted to discuss, which is the ASPECT NP study. It's a phase 3, double-blind, multinational, non-inferiority studies, which compared the ceftolozane, tazobactam at a dose doubling the dose of the usual dose that you use for this antibiotic, 3 grams every 8 hours, compared to meropenem, 1 gram Q 8 hours. All patients were ventilated. All patients were hospitalized, had a hospitalized acquired pneumonia or a ventilator-associated pneumonia. And they looked at two main outcomes, as you can see in this slide, which is the test of cure visit. And the other important outcome was the day 28 visit, which is the mortality at day 28. The primary efficacy point was, or the primary endpoint was the mortality at 28 days. Here is the main outcome, which is the non-inferiority to the meropenem at day 28. This is the ITT population, intent to treat population. You can see the primary endpoint in the orange color is the patient died who received ceftazidime tazobactam, and the blue color is the patient who died who received the meropenem. And you can see the confidence interval between -5 to 7.4. So the non-inferiority margin was met, and the drug was considered non-inferior to meropenem for treatment of patients with mechanically ventilated hospital-acquired pneumonia. When these data were stratified in terms of the patients, type of patients I mentioned earlier, so VAB patients versus ventilated HAB, again, there was non-inferiority margin was met. In fact, you can see here that numerically that the mortality were much higher in the meropenem group compared to the ceftazidime tazobactam group. Of course, this is a subgroup analysis, but the main point is that the primary endpoint was met in this study. Here is again the mortality, but in a different subgroup, and you can see in all these subgroups in this forest plot, you can see that those two antibiotics were similar in all the subgroups treated for pneumonia. And the other important endpoint, I think, was the clinical resolution or clinical cure or resolution of the symptoms. Sure. Secondary point, there was no major difference between the two groups, and this is again the MITT population. We're looking or stratifying patients based on the bacteria, so gram-negative versus Pseudomonas versus Enterobacterales, and the two antibiotics were similar in both. This is also the microbiological resolution or the clearance of the bacteria. And again, we're similar between the two groups. I think in the last 2 minutes, I just wanted to mention this study that we published earlier in the year. We looked at comparing the ceftazidime tazobactam versus colistin in a patients with multi-drug resistant Pseudomonas. So all patients admitted in this study were multi-drug resistant Pseudomonas treated with either ceftazidime tazobactam or a combination with a colistin, so either beta-lactams or other antibiotics combined with colistin. Although this was a retrospective study, but the number were good, and we used univariate and multivariable analysis to identify independent predictor and to see if the ceftazidime tazobactam was an independent predictor for success for those patients. So very good number of patients, 184 patients were included, multi-center, at least 5 centers were participating in this studies. 82 patients received ceftazidime tazobactam, and 100 patients received colistin-based regimen. Here is the primary outcome in the top of the slides. You can see that the clinical cure, 77% in the ceftazidime arm versus 57% in the IV colistin combination arm. So clearly there was a difference, and this difference was significant with an odds ratio of 2.2. in-hospital mortality also was lower in the ceftazidime to tazobactam group, and was actually striking, and I think it's important for us and for everyone, is that the rate of acute kidney injury was much less in the ceftazidime tazobactam group. And you can see in the bottom, you can see this table showing the multivariable logistic regression showed that ceftazidime tazobactam for management of patients with multi-drug resistance Pseudomonas was significantly or independent predictor for success or clinical cure with an odds ratio of 2.4. I think the take-home messages that the rate of Pseudomonas resistance to commonly utilized antibiotics is high, in particular this group, the critically ill patients group. The ceftazidime tazobactam demonstrates significant enhancement against Pseudomonas aeruginosa and very limited cross-resistance with other beta-lactams. And in the retrospective study that I showed, consistent with other real-world data, ceftazidime was associated with higher rate of clinical cure and lower rate of AKI in treatment of patients with MDR Pseudomonas. And lastly, which I think is very important for us in terms of pharmacokinetics, that in ventilated pneumonia patients, 3 gram, which is a double the usual dose, yielded ELF exposure considered adequate, or at least covering the MIC for the gram-negative bacteria. Thank you.
Good evening, Assalamu alaikum. Yusuf Al-Sayed. Thank you very much for congratulations, actually, for making it to the last 2 sessions. You're the champs. We're almost there. So our next session will be Philips, one of our diamond sponsors. We thank you for sponsoring us. It will be presented by Mr. Mazen Darwish, who is the Business Development Manager at Philips. And he will be talking about the medical device integration, how to make your data glow. So, Mr. Mazen.
Assalamu alaikum. We are almost there.
This is Fresenius. We're Philips.
Thanks everyone for attending this session. So did you know that 99% of the medical devices data, or let's call it the patient data, produced by a medical device is not recorded in the EMR? But the question is, how important is to record this data in the EMR? To answer this question, we need to understand the challenges that caregivers are facing in the hospital related to patient data. Let's take an example. In a typical ICU, a caregiver will be facing a lot of challenges related to patient data and recording patient data. Devices and health systems are so diverse, and each one of them is diverse and speaking into silos. And this is bringing all sorts of challenges to
make nurses and doctors chart this data manually from different systems. Also, there is a study in the US that shows each patient in the ICU can produce up to 1 million data points per hour. So we are talking about 24 million data points in 24 hours. It is impossible for a human being to record this data and to transfer it into actionable insights. So by solving medical devices data challenges, we are trying to optimize the efficiency in the hospital by reducing the steps related to the workflow that needed to chart the data manually, and we are enhancing patient safety by eliminating errors related to charting manually. Majority of nurses in an industry survey see benefits of integrating devices. 93% strongly agreed that medical devices should be able to seamlessly share data automatically. Nearly 3 in 4, or 74% nurses strongly agreed that it is a burden to coordinate data collected by medical devices. And 91% said that they would spend more hands-on time with their patients if they could spend less time dealing with the devices. So how do we solve these challenges? We simply created a platform, a vendor-neutral platform. We call it a medical devices information platform consisting of software and hardware. This platform, it allows you to collect data from more than 1,100 medical devices. And when we say we are integrating medical devices data, maybe the question is, what data do we integrate? Simply, we integrate everything, clinical and non-clinical. Clinical data could be anything related to heart rate, blood pressure, waveforms, patient ID, therapy details, but non-clinical data, what could it be? It can be anything related to battery life of the device, serial number, running hours, and this data is important if the hospital is planning to acquire an asset management solution to show you, for example, if I have 10 ventilators in an ICU department, am I utilizing these ventilators in full? Should I transfer some of it to another department? So we are taking all this data and we are pushing it to any software you have. Maybe the other question is, how do we integrate data? We do it in multiple ways. We can do integration by software only. Sometimes in the ICU, you do have patient monitors are sending data already to the central station. So the data is already popping up in the central station. We simply take this data from the central station and integrate it with the EMR or any other software. But the question is, how about if you have some standalone devices like a ventilator, CRRT machine, blood warmer, incubator, you name it. What do we do with these devices? We simply need a connectivity hub. That connectivity hub could be our intelligent connectivity hub, Neuron 3, or it could be our simple connectivity hub, Axon. Neuron 3, as you see, it's a connectivity hub with a touch screen. The first advantage, you will be able to see what device is connected to the connectivity hub and the status of connectivity. So technically speaking, I don't need to wait until I go to the EMR, I open the patient profile, and all of a sudden I don't see the patient data popping up. In case there is any disconnectivity in any of the devices, it will pop up automatically on the screen, and there is a red alarm. It will be shown in the screen. The second advantage, it is a scenario applicable in the hospital, which is a patient transfer. If I'm taking a patient, for example, from the ICU to the OR, Neuron is the best device for this scenario because it has a battery backup and data caching. So in case I go in the elevator or I take a patient from the ICU to the OR, I can take a Neuron with me wherever the patient goes, and the Neuron 3 will guarantee a zero-gap patient monitoring during the patient journey anywhere in the hospital. Also, I think cyber biosecurity is a big topic nowadays in the hospitals. Everything Neuron is extracting out of a medical device is encrypted. Axon is the basic version. It can integrate all the data. It is capable of doing a bed ID integration. It is capable of sending data by Wi-Fi or through the hospital network. So simply, we do have two connectivity hubs, Axon and the Neuron, and it depends on the usage and the application in each hospital. This is a simple format, few slides talking about the devices integration. And in case you have any questions, and if you would like to see the devices in action, we have it at Philips booth. Thanks a lot, everyone.
Thank you, Mr. Mazen. And for our final session, to our Fresenius Kabi, our third diamond sponsor, it's going to be Mr. Rami Shalati, who's going to present to us the clinical advantage of total intravenous anesthesia. Please, Mr. Rami.
Hello, assalamu alaikum. Okay, so basically it's not the advantages of total intravenous anesthesia, and we're going to talk about the Connox, which is the new innovative device in the monitoring depth of anesthesia and nociception. So Connox, it's a new device. It's acquired by Fresenius Kabi, and it's measuring the depth of anesthesia in the OR and ICU. It is the analgesia sedation monitor with the patient with a good EEG. The Connox can give an information about the general state of the patients in terms of sedation level and in terms of analgesia level. So the Connox as a whole, in a whole, can measure the QCon and the QNOX, which is the two indicators. The QCon, it's for sedation level and consciousness level, and the QNOX is for measuring the analgesia level. So that means that one device with two indexes and one monitor, one device with one monitor can give two indexes with one sensor. So why do we need to use a Connox, and what is the importance of using the Connox in the OR or ICU? It is because to give an adequate and the proper dose of anesthesia and analgesia, because the low dose of anesthesia can lead to the high blood pressure, the anxiety. The patient can respond to the external stimulation. The patient can suffer from respiratory depression, respiratory function, cardiovascular function. And the high dose of anesthesia can also lead to the respiratory functions, cardiovascular functions, difficulties to wake up after the surgery. And the same thing for analgesic dose. The low dose of analgesia can lead to the high blood pressure, the anxiety. Patient can move during the surgery and can respond to the external stimulation. And if the patient get a high dose of analgesia, the patients can have a risk of apnea, stupor, meiosis, hypothermia, nausea, and vomiting, anxiety. So that's why we should have a solution. That solution can give like the adequate dose of analgesia and anesthesia. So where to use the Connox? We can use the Connox in the OR, and we can use the Connox in the ICU. So for the OR, the Connox can measure the anesthesia, can measure the nociception, and inside the ICU, the Connox can measure the sedation and nociception. So the two main indices in the Connox, we have a QCon. The QCon is for measuring the awareness and the consciousness during the surgery. And we have the QNOX for measuring the nociception. The QCon, starting when they start induction the anesthesia, it starts with the parameter 99, where the patient is awake. And then after that, when we start inducting the anesthesia dose, This reading, it goes lower and lower, and once it's reached to the 60 to 80, the patient will be in sedative or light anesthesia. The target to be the patient to be in between 40 and 60. So the 40 and 60, the patient will be in adequate anesthesia. If it goes lower than 40, from 20 to 40, then the patient will be in the deep anesthesia, and for 0, it will be isoelectric EEG. Also, we have an option in the device itself to make an alarm in case that the reading of the QCon goes under the 40. The QNOX, the QNOX it also has the same reading when the patient is awake. The reading will start from 99, and when we start the dose of analgesia, this reading, it will go down and down. So in the reading of 99, the patient will be likely to respond to Nexius stimulation. When reach the target of 40 to 60, this is the target, then the patient will be unlikely to respond to any external stimulation. From 20 to 40, then will be very low probability for responding to any external stimulation. So we have to adequate and make the balance of the dose of the analgesia to be between 40 and 60. So what is the QNOX index? QNOX index is the probability of reacting to the external stimulation, which means that the patient will be sensitive, which means the sensitivity. That means that when the patient has less sensitivity, the patient needs more analgesia, and the QNOX will be decreased. For example, the external stimulation like the laryngoscopy. So the laryngoscopy, it's external stimulation. And when we start the laryngoscopy, we see that the QNOX is increasing. Same for the laryngomuscular, airway mask. Also, the QNOX is start increasing. This is what we call the external stimulation. So when we start giving the remifentanil, the QNOX get low and low. Another indices on the same device, the CONOX. So along with the QCon and QNOX, we have a PSR. PSR is the burst suppression ratio, which the percentage of flat EEG over the 30 seconds. We have the EMG. EMG, it's electromyogram. This is the electrical activity of the facial muscles. If the patient got, if there is any movement in the facial muscles, then the EMG reading, it will get effect. And the signal quality index that ensure and guarantee that the index and the sensor of the CONOX is in the right position. Also, we have the sensor impedance that makes sure that you are putting the sensors on the right position. And the 111 means that the sensor is in the right position. If you get 2 or 3, that means you have to adjust the sensor on the forehead of the patient. And also we have, on the device itself, we have the test impedance. So this can be also applied and test the impedance position that on the right position. And we have also the status of the CONOX. So before anesthesia inductions, we have to prepare the skin of the patient. It's not allowed to clean the skin of the patient by alcohol, because alcohol can create a layer between the electrodes and the skin. So if the forehead needs to clean, then you have to use a saline and then dry the skin and then apply the sensor. After that, the electrode positioning, we have 3 electrodes on the sensors, number 1 and 2 and 3. So number 1 will be in the middle of the front head. Number 3, it will be on the temple, either right or left. And the number 2, it will be between 1 and 3. Once we apply the sensors, we don't have to do any pressure or any press on the sensor, because there is like some kind of gel on the sensors that it might goes out and then the sensor can fall down. Then after that, we connect the sensor to the cable that connected to the device itself. So the use of CONOX, or the benefits of using the CONOX, is to reduce the patient sedation level, and it gives like better adjustment analgesia concentration, which will lead to better adjustment of hypnotics and opioid balance. It will reduce the drug administered and better patient recovery after the surgery, and reduction the mechanical ventilation duration, and therefore reduce the stay on the ICU. There is a multiple studies, clinical studies for the Connox. So I choose some studies here and based on some perspective. So first one in terms of general anesthesia validations. This study was subjected with the assessment level of consciousness during the propofol anesthesia and was measuring the PES and AAI and effect concentration of propofol and the QCon, which is the Connox indicator. So the Connox, the QCon, performed same as BES and AAI and the effect side of propofol in the 3 clinical signs, which is the OAS and the loss of eyelash reflex and the reaction of nucleus stimulation. The QCon can be used as accurate indicator during the anesthesia by propofol. The second study is the monitoring of hypnotic effect with the QCon during the general anesthesia. So here we analyze the EEG to find a specific indicators for hypnotic effects. It was 60 patients on this study and using the TCI system for propofol and remifentanil. And they measured that the QCon versus the BES, and during the general anesthesia, the propofol and remifentanil QCon was able to detect the loss of consciousness of the patient. And during the general anesthesia, the QCon decreased the value between 40 to 60, which is our target on the device. In terms of sedation validation, validation index, validation of new indexes, the QCon for assessment of the level of consciousness during the sedation. So we compare here the Ramsey sedation scale versus QCon and BES, and we found that there is a strong correlation between the Ramsey sedation scale and the QCon, but the difference here, which is the most important, that the variation, so you can see that the stability here, the stability between the BES and the QCon, it shows here the QCon how much is stable versus the BES. Okay, so I have only 2 minutes. I have to move a bit fast. In terms of improved outcomes, here a study, it's preoperative depth of anesthesia assessed with the QCon, and that may reduce to post-operative opioid requirement. This is the goal of this study was to evaluate the possible relation between the depth of anesthesia assessment and the QCon and consumption of morphine post-operatively. The method for this study was for the 50 females, had a surgery of elective abdominal hysterectomy, and using the propofol and remifentanil, and using the BCA pump for giving the morphine, and the EEG registered before the induction of anesthesia and during the whole procedure. So here we found the result. It was 2 groups, groups with the high dose, groups with the mean of the QCon more than 55, and the group low with the mean of QCon less than 55. And the group, the high group, they need to have 0.3 microgram per kg of morphine and using the BCA frequently, while the low dose, the group low, using the 0.17 milligram per kilogram, and the reduction of morphine consumption was 25% less. Okay, that means that the measuring of QCon can reduce consumption of morphine. We have to finalize. Okay, so I have to finalize here. We have some other studies. Only the last slide here. There is another studies. We can share it with you upon your request. And the device itself, it's available in our booth outside, so you can pass by and we can talk more about it. We have a device called Connox Lite. It gives the same measurement of the Connox, the QCon and the QNOX, and can be connected to the Philips monitor. So if you have a Philips monitors, you can connect the Connox light and get the same reading. Okay? So this is everything about the Connox. Thank you for giving this opportunity, and thanks for your attention.
Ladies and gentlemen, finally, thank you very much for being with us today. Hope you enjoyed it, and we'll see you tomorrow morning, inshallah. Thank you.